All right. Any all in favor? Aye. No opposed? Okay. Good. Commissioners, you've received all the written updates from all the centers, directors. You've had a chance to read them. Commissioners, do any of you have any questions on the updates you received at all? Anyone? Okay. Yes.
The one update on the healthcare data breach assessment, that's still targeted for November. Is that on track to come out at the end of the month?
It's December. Or scheduled for December now.
Yeah. Angela Avant, are you available, Angela?
So, Mr. Chairman, if I could. So I had a couple of late-breaking items I wanted to alert the Commission to. On the agenda today, we have agenda item 6, which is the consideration of the privacy and security regulations adoption as proposed final regs. Last night, we had a lengthy conversation with the Attorney General's Health Consumer Group. They raised some questions. We think we resolved all of those questions, but we think that given the lateness of time in which we were making those changes, that we should run the changes back before the Health Education and Advisory Group before we bring them back to the Commission. The issue that you would be considering today relates to the treatment of sensitive healthcare information, which is a level of information deemed more sensitive than typical PHI. The Commission would have acted today to align state regulations with what's in place federally, and involves the use of a software tool developed by SAMHSA, the consent to what's called consent to share, and there were questions raised by HEAU yesterday about the ability of the consumers to granularly approve information as it's passed through the information network that data is transmitted through. So we decided that we wanted to have absolute clarity, wanted to have understanding and agreement on the part of our colleagues in the AG's office before we brought them to you. I think David Sharpen and Angela are going to come up and explain a little bit about that, but before I do, I also wanted to mention that we had a lot of support for our Where the Cost website. We've gotten a number of inquiries from the media, which we've answered. We've also received a number of questions from several hospitals and physician groups. We are planning to meet with those organizations over the next several weeks to resolve any questions. I think the point is, as we continue to roll this out, we will do so in a prudent but persistent way, expanding on the scope of payers that are going to be subject to the Where the Cost framework, as well as broadening it to additional episodes. Keep in mind that there are almost 90 episodes of care that we could present using the Prometheus software, and we chose only 4, which we thought were extremely shoppable, also in which the prices we thought were extremely stable, and we could definitely could justify presenting that information. We're going to move forward, but we want to move with all of our stakeholders understanding, if not agreeing, what we plan to do. So I'll pause here, and if there are no questions, yield to David and Angela to talk about this consent to share framework.
So good afternoon, Mr. Chairman, members of the Commission. Angela, could you just take a moment to frame up the changes we were going to do in the regulation, and I'll step in on this.
Sure. So we aim to, as been mentioned, align our regulations with the federal rules around the exchange of sensitive health information, in particular Part 2 information for substance use and treatment programs. Under the current regulations, we only allow HIEs to exchange sensitive information through a secure email, or what we're calling point-to-point. But the changes would allow the exchange of information beyond just one-to-one or point-to-point using the HIE, where a patient would be able to essentially redact certain pieces of their medical record and make that available to those providers that they authorize, which is in alignment with the federal regulations.
Thank you. So just briefly, let me tell you a little bit about the technology that Ben highlighted. I think everyone knows what SAMHSA means, or who SAMHSA is, a federal agency, but if in doubt, it's the Substance Abuse and Mental Health Services Administration. And back in January of this year, they introduced a final rule which became effective in February. It was aimed at promoting the use or encouraging the use of electronic health information exchange for Part 2 level information. And this is the first revision they've had in that rule since 1987. And prior to that, it was 1975, which was the change preceding. What this technology is aimed to do, it's an open source technology, and it really has two layers. It's a management of consent, and it's also access. There's the two layers the technology has. SAMHSA engaged an organization out of Columbia, FEI, who developed this model called Consent to Share. The idea behind it is using open source standards called a DS4P, Data Segmentation for Privacy, that was put together under the leadership of ONC, working with the Veterans Administration, CMS, and other entities to come up with what these privacy standards would look like. Some aspects of Consent to Share, which began rolling out several years ago beyond the pilot, is it's a multi-device user interface. It works off of two layers of authentication, what you know and what you have. It captures patient consent, and that's probably the most important thing to take away from. It allows the users, if they wish, to have their Part 2 information exchanged or flow through an HIE. They can go in and set up that exchange, the types of information, coded data, that they want released, and identify to whom they want it released to and when that consent expires. It works off of coded data, so it's not the practitioner note. It's simply structured ICD-10 type data. It's medication information. And it allows the patient to test their medical record to see what it looks like when the information has been redacted. So it also includes a number of educational components to inform the consumer what it means to be engaged in this and what can happen to the data. In the regulations at the federal level, and we've pointed to them again at the state level in the draft, is that there's limitations. There is no ability to redisclose this information. Essentially, they're not permitted to. One of the projects that SAMHSA is working on in the future will allow the technology to be tagged within an EHR. So it uses metadata to prevent anything from, so to speak, slipping through the cracks. It is available under the 2015 certification from ONC for an EHR. It is not available in earlier versions. Today, they rely on data segmentation through the consent process to redact what would be in the medical record. So we were essentially going to be enabling HIEs to use this type of open source software in the regulations that we were going to bring forward today. We think taking them back and building on some of the feedback we heard from the ACAU may be helpful as a next step. And we plan to come back to you all probably January with proposed at that point. So I can pause if there are questions on the technology. I'm happy to take them, or Angela has questions on anything we can help you with.
Commissioner?
Yes, I just had a little question in terms of, because, among the feds, this was quite controversial and quite opposed by those people, both kind of working with the department and within the department, who had to worry about costs and tracking and risk adjustment, anything where you'd really like to know the full spend, complete cost of care on a particular individual. And now you were pulling this off and potentially having very expensive people with a lot of complications, and you were blind to it. So, and as you laid out in the timeline, this was sort of a last thing out the door for the Obama folks is there any chance before we conform to a federal regulation that there might not be a revision of that federal regulation with a new administration? And again, I mean, this wasn't a particularly partisan thing, but it was definitely a nod towards the mental health substance abuse people over, you know, the chief actuary of Medicare and, you know, other people who certainly had, who are serious kind of policy players within that environment. So do we know whether, has everything settled out, or is there some chance, like when you talk about how quickly we should move, is there, I don't want us to move quickly to come into sync with a federal regulation and then the feds change it 2 months later.
So what I can tell you along those lines is that when the regulation was introduced in January, it has that 30-day period before it becomes effective. The current administration decided to delay it for 30 days so they could review the final rule. What happened in those 30 days, I'm uncertain, but they allowed it to go forward. But I am unclear what it might mean for the future because anything is possible.
So
Commissioner Sargent.
my high-level reading this is we're trying to broaden our regulations to permit HIEs to go the full scope of the federal regulations. And right now, we're more limited in what we allow.
So I think what we're saying specifically as it relates to Part 2 type information, we are aligning with what exists at the federal level cautiously and keeping an eye on that because we try to make sure our regulations facilitate the exchange of information as opposed to prevent it. So yes, in short, we are working to align on the Part 2 aspect.
And I guess what I'd like to know, it troubles me a little bit, it looks to me like we're just trying to go to the full scope of at least of what's allowed under the federal regulations. If the health advocacy unit is trying to cut that back, I'm going to want to see what it is in Maryland we've decided to not allow that you could do under the Fed. Because, you know, which part of that is a special Maryland law? Because we like to regulate stuff. When, if you're doing the national standard, you could go a little farther. I'd like to see that if we're not going the full way of what's permitted under the federal regulation.
Yeah, I think that's a good point.
Any further questions? Thank you, David. Angela, I think you have another announcement, don't you? Want to make sure.
Go ahead.
Okay.
So I just wanted to give you guys a quick update. We are planning on releasing our round 6 telehealth grants. As you know, over the last 3 years, we've issued several telehealth grants to 12 organizations and are releasing our 6th. This telehealth grant is aiming to address a particular issue in the healthcare industry in terms of medication management. As you might know, medication issues with patients cost hospitals a lot of money, and non-adherence to medication can also cost the healthcare system a great deal. The increased movement toward alternative care delivery models has established pharmacists as an important part of the care team, but our small independent practices in the state of Maryland sometimes don't have time or the in-house pharmacist specialists to more effectively provide medication management. Given this challenge, we worked with stakeholders to develop a telehealth use case that we could use as a framework for this grant announcement. The grant will be for an 18-month period, as we typically do, to allow for time to ramp up and collection of data. It'll be in the amount of up to $150,000. The grant has 2 main objectives, one clinical and one more technology or HIE focused. The first being providing the specialist pharmacist support to aid healthcare professionals in managing the therapeutic regimens of their patients, facilitating medication compliance and adherence for patients, and providing education information to patients and their caregivers. We also, through telehealth, we also believe that telehealth and care coordination and care teams really requires electronic health information exchange efficiently. So this use case or this grant will also have an HIE component. The awardee, in partnership with CRIS, will test a health information exchange use case to support the sharing and increase awareness and availability of a reconciled medication list and any changes to that list. So this is just beyond just having the prescription history of that patient. So we believe those two components can result in a successful medication management use case and telehealth project. So we'll release that this month. We're hoping to receive applications in January. We've had significant interest from the stakeholder community for this grant. We'll have an evaluation committee, as we usually do, to evaluate the applications and potentially award in March. And we'll hopefully be back before you guys to inform you about the progress in November, at the end of next year, and then final deliverable September 2018.
Thank you very much, Angela. Thank you very, very much. Does anyone have any questions for Angela? Any commissioners? Thank you very much, Angela. We have some changes at the Center for Health Care Facilities Planning and Development. Mr. McDonald and Mr. Parker, fill us up. Yeah. All right. I'd like to introduce Mariana Brando. Mariana joins us from where she was office at the college now for 2 years. She earned a master's degree in public health from Florida A&M, and since then has worked in various public health programs in the state of Florida and Washington. I've been a very busy time in the CLA, and we're very glad to have her. Well, thank you very much. Congratulations. Oh my goodness. Member of our healthcare development planning division for the last 3 years. Kathy has done great work with Eileen Fleck, operating the state health plan chapter for Morgantown. Services chapter that we looked at several months ago. Also did a lot of work on a new chapter regulations. Recently, in the last year, another and work with Eric Dorian with the Rural Healthcare Delivery Work Development. Taking an executive position with an organization for social work. That's an organization that promotes health equity, the access to comprehensive quality care for all Marylanders. And wanted to thank her for the great work she's done here in the last 2 years. Absolutely. Thank you very much, Kathy. Okay. Ladies and gentlemen, commissioners, the Leapfrog Group released their 2017 hospital patient safety grade results last month. For the first time, Maryland hospitals have been included in the national scoring system. I warn you that the results are not as positive as we had hoped, but I also emphasize that this is indeed nothing more than a first step. One of the Commission's greatest services to the public is to shine a light on our successes, but also some of our problems. And that is the way in which we can improve the system, make improvements where they are needed, and improve the overall outcome for our citizens. The results from this Leapfrog report hopefully will contribute to our efforts to improve the transparency and the quality and safety of Maryland's hospitals. To make a presentation on this, we're asking Lee Binder, who is the president and CEO of the Leapfrog Group. She's going to review their efforts to make our system more transparent and to improve safety and quality in the state of Maryland. Lee, on behalf of the Commission, we really appreciate your appearing here today. This is something that has been of great interest to all members of the Commission. We are desperately concerned about the importance of improving our hospitals. I will say this before you begin. The fact that all of the results were not exactly what we had hoped for, we expected, for us is not entirely unexpected. Over the past year, the staff has apprised us of some weaknesses in the quality performance of Maryland hospitals. And of course, we also had corroborating evidence from CMS and some others. So we know that we have to improve, and we're very, very happy you're here to help us at least start along that road. So thank you very much for coming.
Well, thank you for having me. I was here, I think it's about a year and a half ago, talking about this issue and urging the Commission to get us this data that we need in order to give these grades to Maryland hospitals. And I want that not only from my role at Leapfrog, but from my role as a citizen of the state. So I really care about it, and I really appreciate Chairman Moffitt, your leadership and the leadership of this Commission and the staff. Stefan and Tereska have been extraordinary. This was not easy to put together the kind of information that we needed to be able to show how Maryland hospitals perform on safety compared to the rest of the country. But it's a great service to the state and to the citizens. So I really thank you again for your leadership. So today, I'm going to give you a little bit of an overview of how it went. We publicly released the grades on October 31st, although they were shared with the hospitals well in advance of that, as well as many others here in the state were able to see how the grades looked and how the numbers looked. I'm going to show you how Maryland hospitals did. I'm going to give you an idea of some of the media coverage, just a little brief overview of how that media coverage looked, and then some observations for the future. So first, I'll give you a bit of an overview on how we calculate these grades, this A, B, C, D, or F. Well, first of all, we bring together the Leapfrog team. And so the Leapfrog team, we are a nonprofit. We're based in DC, and we've been around for 17 years. We were founded in 2000 by a group of purchasers, large employers. So some of their logos are on the slide, but Boeing, FedEx, Marriott, GE, they were among the founders. The Business Roundtable helped to support the launch of Leapfrog, was very influential and remains on our board. And the idea that these employers had was that all hospitals ought to be held to the same level of market transparency that their own products and services are held to. So the simple idea, for example, from Ford and GM, both of whom were part of that launch, was all of our cars are on every newsstand in the country, and they are compared in great detail to all of our competitors. And we think that's a good way for people to buy cars. But why is it that we're spending more on health benefits than we earn in profits, and our employees do not have the same information to use when they're comparing hospitals or making such an important decision in their life about where to seek hospital care or health care? And at that time, back in 2000, there was virtually no information on hospitals. And even today, I would argue there's not enough, but there's a lot more. And that's very much partly to the credit of Leapfrog, for sure, and these original founders, and certainly partly to the credit of folks like you who really insisted that this needs to be made public. So we were founded with the idea of giant leaps forward in safety and quality of U.S. healthcare. So they didn't name it the Incremental Change Group. It was Leapfrog. We wanted really significant change. So we have two programs today, And I'm going to focus today on the grade, but just to give you a sense of how these two programs interact. We have what's called the Leapfrog Hospital Survey. That is an annual survey. We launched it back in 2000 with those original founders. We ask hospitals to voluntarily report to us on a set of mostly safety measures and some quality measures that we can't get anywhere else that aren't available in claims. And hospitals choose to voluntarily report. Back when we started, about 200 hospitals in the country first reported. Now across the country, it's almost 2,000. And hospitals report for a variety of reasons, but I think the main impetus to start reporting is because employers in their community ask them to. There are hundreds of employers involved and active with Leapfrog, and they ask to please report to Leapfrog. It's free for them to report. It takes about 40 to 80 hours of staff time, so it's some work, but it's not impossible, and hospitals have tended to find it useful to their quality improvement efforts to do so. So we collect a lot of data from that survey, again, that we can't get anywhere else. The second program we have is not a voluntary program. It's called the Hospital Safety Grade, the Leapfrog Hospital Safety Grade, and that's that A, B, C, D, or F that we assign all general hospitals in the United States for which we have data. And Maryland was exempt from that because we didn't have data, but now you aren't. But we offer these grades, and we use mostly CMS data to calculate them. So the way that we calculate those grades is we bring together, we have a survey team, we have a set of experts, faculty, as well as a blue ribbon, we call it a blue ribbon expert panel that comes together to evaluate what measures are out there, if the evidence remains good about the value of those measures of safety. They also review what other measures may be available routinely. So this work takes place continually throughout the year. It's not something we do once and that's it. That's how we calculate the grades. We continually update to be absolutely at the cutting edge of where the evidence is. Our sources right now are three main sources. We use CMS data, and in this case, we worked with HSCRC data to be comparable to what we got from CMS for other states. We also use some data from AHA that's available, and then we use some data from the Leapfrog Hospital Survey when we have it. When we don't have it, we don't use it. It counts neither for or against the hospital if they don't voluntarily report to the survey. And I'll talk briefly later about how that plays out. We weight the measures based on evidence. So is this measure truly something we know from a wide body of evidence has an impact on people's safety in a hospital? Its impact, so to the extent to which this really harms people and a lot of people, and opportunity, meaning does this particular measure show variation in performance? And then finally, we grade hospitals on a curve. So what we stand behind is the fact that A hospitals tend to be safer than B hospitals, which tend to be safer than C hospitals. There's a mean in the center of the curve, and we grade hospitals according to where they array next to that curve. This is a slide that shows our current expert panel. They all serve certain terms. We've had really a dream team of experts, both when we started 5 years ago with this grade to now. They are in continuing set of just truly dream team experts, foremost experts in patient safety across the country. And all of these panelists serve as volunteers. They believe so strongly in the importance of transparency and putting patient safety on the top of the agenda nationally that they have agreed to serve voluntarily. And so I am endlessly grateful for their work, which I think is so important to making sure the integrity of this grade remains top-notch. We look at 27 measures. So each of the grades looks at up to 27 measures of safety, meaning errors, accidents, injuries, infections that happen in hospitals. This is a list of the measures we look at. Of course, I'm always happy to answer any questions about them, but they are in 5 main categories: infections, problems that happen with surgery, including some never events like objects left in, or other kinds of problems such as punctures, lacerations. We look at practices in place to prevent errors. It's important to us that a hospital may do well in one given moment in time on not having an excess number of infections or errors or injuries, but do they also have in place the practices, the management structure to prevent them from happening in the future? We want this to be sustainable, not just a one-off, big campaign, we're going to reduce infections, it's over. It's never over. Safety is something that has to be 24 hours for a hospital, 24 hours every minute, always on the top of the agenda. So do they have in place a structure that really enforces that principle? And then we look at other general safety problems, including some such as air embolism that can kill a patient, for example. We look at general safety issues that are unfortunately more common than we would hope in hospitals. And then finally, we look at some staffing issues. A lot of those come from patients themselves. There's a survey that CMS asks all hospitals to report on, and you report on as well. It's an HCAHPS survey. And some of the questions in the HCAHPS survey actually have been shown in some evidence to correlate with actual patient safety outcomes. And those are the ones we look at. So for example, there's questions in there about how patients perceive their communication with their doctors. Do they understand their treatment plan, et cetera? Communication with nurses, similar. And those have been shown to really correlate directly with infection rates. So we have included information about that survey as well. And we look at whether the hospital has in place endorsed safe practices around staffing levels for ICUs and for nursing. So that's how we calculate the score. This is how Maryland hospitals did. So as Chairman Moffitt mentioned, the answer is not very well this time. Maryland was 46th among the states, so fourth from the bottom in percentage of A hospitals, which is one way of looking at it. But anyway, we would gauge Maryland's performance relative to other states would not be favorable. I can tell you it was a unfortunate and disappointing performance for the first time out. But I should say we update these scores every 6 months for a reason, and we see changes frequently every 6 months. So I will be looking forward to seeing the next round. Here's how Maryland hospitals did relative to to the rest of the country. So across the country, we give almost a third of the hospitals an A. And Maryland had one hospital, 2% of your hospitals getting an A. Across the country, you get about 25% of hospitals a B, and Maryland was 16%. We give 37% of hospitals a C, and Maryland hospitals, it was 61% got a C. And then we give Ds and Fs. We're pretty sparing in our Ds and Fs, but we do give them, and we give about 11% of hospitals, or no, I'm sorry, 6.5% of hospitals nationally get a D or an F. In Maryland, it was 9 hospitals in the D or F category, so it was also disturbing from that perspective. But I will say in this area, there was incredible variation when you look even just statewide. So I just showed you Maryland hospital performance, which was disappointing. DC hospital performance is even more disappointing, if that's even possible. It is possible. DC had no A hospitals, and DC also had 2 F hospitals. And there's only about 15 Fs nationally, so it is really upsetting to me as a resident of the region to see 2 of them in DC. And then there's 3 D hospitals in DC. So DC, very disappointing performance. By contrast, Virginia is one of our top states. Virginia has 60% of their hospitals in the A category, 22% Bs and 18% Cs, really outstanding, and no Ds and Fs. So I think there's been a lot of effort, and I think driven by the Virginia Hospital Association, to improve safety. I mean, they've had a very strong campaign in that state, and it's paid off. These are very, very good results for Virginia. So we get the question a lot, do you have to participate in the Leapfrog Hospital survey to get an A? Because we do the survey, so I think there's an assumption that we're maybe using the grade to get people to report or something that is biasing. Now, as I said earlier, if a hospital does not report to Leapfrog, we don't use that data, and it counts neither for or against. We just NA it out. It's neutral. But by not using that data, we put a heavier weight on other measures that are in there. So if you do poorly on CMS measures and you don't report to Leapfrog, those CMS measures are going to have a heavier weight than if you did report to Leapfrog, so we have more information. But I think also on a philosophical ground, if you don't report to Leapfrog, you're not telling your story fully. Your citizens and residents and your community does not understand exactly how you're doing on safety. They have much less information because the Leapfrog data tells us things we simply can't get anywhere else. It's very important. For example, Leapfrog will tell us how, not just whether you use technology to manage medication orders in the hospital, which medication errors are the #1 most common error in hospitals. Not only do you use technology, but how well it works. The Leapfrog survey has a tool on there to test whether it works. And guess what? They don't always work. So hospitals that test it find that out. And there's no other way for them to find it out, by the way. So this is an opportunity for hospitals to learn that, but it also is an opportunity for us as patients to be aware of which hospitals are doing the very best job of managing those medication errors. One example. There are other examples of areas where we just simply don't know anything about certain categories of safety that are very important, but we don't have any other way except Leapfrog. So from a philosophical point of view, I think every hospital should report to Leapfrog. But if they don't, okay, that's not in there. And in fact, lots of hospitals don't. So here's some really interesting results. So these are some states where we saw some pretty outstanding improvements. Rhode Island went 5 years ago, they were 50th in the country. Now they were #1 this round. Oregon went from 48th in the country to 8th. Wisconsin used to be 44th in the country, 6th. 36th was Hawaii, they are now 3. Idaho is 19th, and they're now 4. So these are states where we've seen significant and sustained improvement in patient safety. And the question of whether they report the Leapfrog is, some of them do and some of them don't. That's really not the main factor in any of them in getting grades. So Rhode Island, majority, but not all of them. Wisconsin, only 6% of hospitals report to Leapfrog, and they're #6 on our list. Maryland has 18%, so Maryland could do a lot better in reporting, but the whether or not a hospital reports to Leapfrog is not a very significant factor in their grade. The grade is really about their safety, and that's what the problem is, and that's where the conversation should be when we're discussing the disappointing performance of Maryland hospitals. Just a side note, in case you have any questions about this, there were 4 hospitals who did not grade. This did come up in some questions, so I just want to be clear. There were 2 of them were ineligible. We only grade general acute care hospitals. So there was 1 rehab hospital and 1 pediatric hospital that are ineligible as a result of that fact. And then finally, there was insufficient data for a couple of hospitals, McCready Memorial and Holy Cross Germantown, because they're fairly new. They just don't have enough caseload to have valid data for them yet. So stay tuned. We publicly report on hospitals on our own website, so you're welcome to check that out, hospitalsafetygrades.org. And there's an example of Howard County General Hospital. That was your 1A hospital. And you can drill down on our website. You can start with just the A, but you can drill down and learn how we got there. So some people may not agree with whether we give them an A, B, C, D, or F. They might not agree with the grade. So we give you the information. You can give them your own grade. There's 5 tabs that reference the categories of safety I mentioned earlier, and you can look underneath those and you can see little gas gauges that tell you if the hospital was at the average for that measure nationally or below or above. There's more information if you scroll down from there even that will show you exactly their numerical value of how they did, how the best hospital in the country did, how the worst hospital did, and some information about that measure and what it means and why you should care about it. You also have an F hospital, as I mentioned, and so you can look up every hospital from A to F and in between. When we put out this grade on October 31st, we generally get a lot of coverage nationally. Certainly we got a lot of coverage here in Maryland as a result of the fact that this was the first time we had Maryland grades. It was covered by most of the major media outlets in the DMV area, as well as I think in Baltimore, the major newspaper as well as the major radio covered it. There were 35 total stories, 11 broadcasts. It was repeatedly broadcast on radio throughout the day, on the release day. I want to say that I was very pleased in some sense by the reaction of hospitals in Maryland. I thought they showed great leadership, and I thought that the way that they responded was reassuring to the public, which really should be the response to an announcement like this. The public wants to know that you're doing everything you can to improve. That's really what they care about, obviously. They're entrusting their lives in your care. They want to know that you're not going to let a bad grade stand, that you're going to do what you can to make sure that anything underneath that grade that might be true about you that's not good is going to improve, because people really are relying on you. And that's basically what their stance was. And I mean, I guess that sounds like, well, obviously that's what they're going to say, but I will tell you that we've been doing this for 5 years, and that is not the typical reaction from hospitals. Often hospitals, and there was one that was more typical, Adventist Shady Grove, which did get a D, said, and this was on the NBC4 website, "We don't believe our grade is a reflection of the care we give at Shady Grove. The information in the report was not complete quality of information." That wasn't a typo, that's what it said. So, but I think they were just, you know, sort of saying it's not true, it can't be right. And I understand the impulse to say that, but I think the reaction like the Maryland Hospital Association had, you know, each and every hospital in Maryland has programs, initiatives in place to make sure the care for patients that patients receive is safe and compassionate. Or as Johns Hopkins said, we strive every day to provide the highest quality and safest care to all our patients. As such, we review and analyze hospital ratings with interest, such as those recently released by Leapfrog. I mean, it's a simple statement. They're not saying we think it's all true. They don't believe that, I'm certain, but they are clearly saying, you know, we're gonna improve, and we believe that it's important that we study these and that we improve. That's an important statement, and it's a responsible one to the public. So I think overall, you know, I think we should be proud of Maryland hospitals for their response to this. And the next thing we'll be really proud of is when they all show A's. So just a couple of thoughts for the future. We'll be doing grade updates. We update every 6 months, as I mentioned earlier. We always see improvements by many hospitals. Sometimes we see not so improved hospitals, but we update every 6 months because things change. Safety is something you can turn around very quickly, and so we want to see that. We want the grades to galvanize improvement. Leapfrog takes no credit for any improvement that we see in any hospital, even though we see lots of great stories out there of hospitals that improve, but they do it themselves. What that means is some very hard work by leadership and by all clinicians and all staff in a hospital to put a priority on safety. It's simple as this. It has to be the top of the priority list for the CEO and every board member. And when it is, suddenly you see change. It galvanizes improvement. That's what we need. We would like to see that happen in Maryland. It can start here. It starts with the public looking at these grades and hopefully and saying, wait a minute, I want to see my hospital improve. And it starts with the hospital themselves, who clearly are prepared to recognize that there is a problem based on their responses in the media. And I hope that they will put the real concerted effort together to improve and perhaps report to the survey. I think Maryland residents deserve to know the full story of how Maryland hospitals are doing. And then finally, it's possible to push for statewide transformation. I showed you the earlier data on the 5 states that went from 50th in the country to 1 or close to that. That's because those states work together. They should be able to work together. Hospitals can learn from each other how to do this best. And then states with leadership like your leadership, insisting that this needs to be a priority, can show change and can make a difference. So I hope that you will all continue to push for statewide transformation. I hope this information helps you to understand where you are, and certainly we will continue to work with you to measure that improvement. And I look forward to coming back maybe a year from now again and telling you, look at that, straight A's. So thank you.
Thank you very much, Ms. Binder. Commissioners, do you have any questions for Ms. Binder? Okay, Commissioner Sargent first.
So do you go to the next step of the analysis in any way, not as part of the survey, but looking at, say, Virginia versus Maryland and the district? What is different? What is Virginia doing? What did Rhode Island do to become #1 that is not being done here? If that's not what Leapfrog does, is there somebody doing that? Because that's the next question I have, is what is the menu of things that are done? Are they regulatory? Are they hospital-centric? What are the costs related to those things?
Well, we're not a research organization, but we do, of course, take a great deal of interest in that exact question. So we have looked in, we've called around to try to sort of understand anecdotally what's the cause of these improvements. And generally, we do see that where there's teamwork of some sort, where hospitals are working together in collaboratives or patient safety organizations, or there are some formal efforts for hospitals to collaborate. We do see some acceleration and improvement. But on an individual hospital level, I'll tell you, it's a whole variety of factors. But they really all come down to that motivation factor. It is not expensive to improve your safety. It doesn't mean investing in the latest robotics or something. It's really about having that will. And I do think that when boards and CEOs and C-suites think it's important, it gets done. So I think there are some researchers who have looked at some of those questions, and I certainly think it's the next, it's a very important research question.
Commissioner Pollack?
Can you talk a little bit about risk adjustment?
A few of the measures are risk adjusted. The infection measures, for example, are adjusted based on the kind of hospital, whether it's an academic medical center or a community hospital. There are differences in the expectations of the infection rates. That's all calculated by the CDC for us. But for a lot of the measures, there is no risk adjustment, and I will be specific about those. There are some measures of never events, for example. Objects left in after surgery, for example, is a never event, like a sponge is left in. You can imagine that is pretty catastrophic for the patient. In some cases, it can kill the patient. In other cases, it means just months of pain and agony. They don't understand where it's coming from. They have to have a repeat of their surgery. That is awful. So, and unfortunately, it does happen. In fact, that is the most common adverse never event that is reported to the Joint Commission. We don't risk adjust for that. We don't believe that there's any reason that you should risk adjust. So that would mean it doesn't matter if the patient is very sick when they go in for an operation, or if they are very healthy or old or young, you shouldn't be leaving a sponge in. So, and lots of folks agree with that.
I'll take that one on, because that response reflects a complete misunderstanding of what gets reported to the Joint Commission as a sponge left in after surgery. Okay. So if you have a patient who's very sick in the operating room and you're going through a series of events to control bleeding, and your plan for making sure that there's no unintentional sponge is to get an x-ray, and you decide you're going to get an x-ray before you leave the operating room, and you get that x-ray on the way out, that's just before the patient wakes up on the table, and it shows there's a sponge, and you reopen the wound and take it out and close it up again because you're moving quickly to get the patient to where the patient needed to be, that gets reported to Medicare as a sponge left in place. That's, at least at our institution, the largest number of sponges left in place that get reported. There's no long-term adverse consequence to the patient at all, and in fact, the overall process probably represents safer care. Yet Medicare doesn't have a sophisticated enough system to understand that at a place where you're taking care of a bunch of very, very sick patients on an ongoing basis. So we've decided, at least at our institution, that we're going to continue to proceed with what's in the best interest of the patient and ignore that safety measure, as long as we know that we're not doing things like letting patients go home with sponges and have long-term consequences of the things you described that are clearly unacceptable and are clearly never events. The problem is we're not measuring everything. The problem is that the measure doesn't get at what you described as a horrible never event that should never occur. We all agree with that. The problem is that the measure doesn't reflect this thing. So, and the challenge, just let me finish here. The challenge with the system, and I agree wholeheartedly with you, that I think our focus has to be on how to improve these things. But when I look at a hospital that's listed as an A, and I see that the patients from that hospital with the most complicated conditions, most likely to lead to what I just described, are being transferred to a hospital like ours that's rated as a C, and I see that we're not risk adjusted, I say that's unfair. And what that tells those hospitals is don't take those patients. Don't get in that business, because you're going to do much better if you focus on the other patients.
Well, that's, as I said, the measures, many of the measures where it's appropriate to risk adjust are risk adjusted. So all of the infection measures are risk adjusted. And the never events, the Joint Commission issued a report. The reason I know it's the #1 most commonly reported sentinel event is because of the Joint Commission's own report on the subject. And also there are ways to avoid having sponges left in without having an X-ray at the end of the procedure. And in fact, the Joint Commission points that out in their own report, but that is not necessarily the best practice.
Yeah.
So I mean,
again,
I'm just saying there's ways to do it that don't involve that.
The description you gave, and you're not the only one, the other people give of that sponge left in place, that's a horrific never event that should never occur. Everybody agrees with that. That's not what the measure is. That's not what's measured. So if you get to the point at the end of the operation and you're planning on going back and addressing other things, that's different than the patient going home and finding something months later. Okay, so you can't call that the same thing. And a large portion of those reports represent those cases.
Well, okay.
We'll bring in
I'll bring in my experts, and you can bring in your experts and argue about it. But I think that's actually one of the measures that has the least controversy. So I'll certainly bring that up with our expert panel, though. I mean, I've never heard a single person say what you just said, but it is not best practice to have an X-ray at the end of the procedure as you're describing. That much I know from the Joint Commission's own report.
And for elective surgery, I agree completely. For the overwhelming majority of elective surgery, I agree completely. But when you've got somebody with 6 gunshot wounds to the belly, and you've gone through, a bunch of challenges, that situation is relevant.
We get a third of the hospitals in the country in A, including a huge number of academic medical centers and hospitals with trauma 1 centers. There is no excuse for not having an A. There isn't. I'm sorry.
Yeah, I don't have a problem with that. I agree with that completely. Okay. I'm just pointing out that and believe me, our focus is on figuring out how to get better, and it has to. That comment you made was dead on. Yeah. It can't be about figuring out what the excuses are. I think it's just important that we get a little bit less, that we recognize that we're not adequately risk adjusting a lot of things.
Okay. Thank you very much, Commissioner Thomas.
So just very briefly, I would agree with my colleague that it's about making things better. And if these reports do that, that's great. But sometimes I've heard them characterized as rank and spank. They get ranked, they get graded, press release, people get spanked. And I like to think that if that led to change, that would be a good thing. But I'm looking here at the Joint Commission on Accreditation of Healthcare, the National Committee on Quality Assurance, American Medical Accreditation Program, American Accreditation Healthcare Commission Utilization Review Accreditation Commission, and the Accreditation Association of Ambulatory Care. All of our hospitals are faced with these accrediting bodies. They can't function if they are not accredited. So what added information does Leapfrog provide that all of these accrediting agencies don't provide, in your opinion?
Information. Do any of those that you just listed make public what they find when they go on the accreditation visit?
No, we
The answer is
typically
no.
don't see their reports as a press release, although
No, I'm asking you,
if they're
you
shut
get
down.
data and information, can I please have your Joint Commission report? No, that's not made public, despite the fact that hospitals rely on that information, rely on the accreditation to be eligible to receive public money through Medicare and Medicaid. That's what, you get a Joint Commission accreditation, that means you can get Medicare. In many states, that's it. So despite that, the information that Joint Commission learns on their accreditation visit and their accreditation reporting is not made public. So none of what you just named is made public. So what we do is make it public.
You make their information public.
No, I don't have their,
You
I
make
wish
your
I had their
information
information.
public.
I don't have it. I make the information that Medicare makes public after
Okay.
people advocated for many years, including us, to get that information made public. But we use that information to give the public a letter grade that they can understand and use.
Okay, this last thing. So you characterize your degree of confidence in the accrediting bodies in aggregate I've just mentioned. You have confidence in what they're...
I'm not sure even how to answer. I've never seen an accreditation report. I have certainly seen that, you know, almost every hospital is accredited. And then when I look at their results, I see that many of those hospitals are dangerous, extremely dangerous, based on the results that we know about some of their infection rates and their error rates. So I guess it's not enough. I don't think it's enough for anyone to rely on accreditation.
Thank you.
Mr. O'Grady.
In terms of thinking about the other accrediting organizations, some of them have been criticized in the past of that somebody gets a bad score or whatever, and then they sell back to them the consulting services of how to fix it. So it doesn't sound like you are in that business. So if I'm a hospital, one of these hospitals, and I've got a C or D, is there an infrastructure? Are there consultants or whatever that help them, or are they? Is there like a little mini industry of how to improve your safety scores and be better by next year, or is that sort of they're on their own?
I think it's a great idea. I wish, and maybe someone will hear this and want to do it, because I think there's a real market, because we get calls from hospitals all the time asking, how do I get my A? I want to get an A. Our CEO wants an A. How do we do it? So, but there are a good number. So there's no product out there that says, here's how you get an A. Put it that way. That's what I think is an opportunity out there. But there are a lot of organizations that do help hospitals and sell them consulting services or other information. There's a nonprofit called IHI, which is excellent and offers a whole variety of just superb information about how to improve your safety. So, I mean, there are National Patient Safety Foundation. So yeah, there are a good number of just excellent organizations to help them. And there's also things called patient safety organizations, which protect data for hospitals, so they can give data to these organizations and work together to figure out how to improve without having to worry they're going to get a lawsuit from, you know, having reported that data. So there's a lot of just great opportunities. We don't do it. We don't pretend to know how to run a hospital. We're not consulting. That's not our thing. We just report what we see.
Thank you.
Okay, thank you very much. Commissioner Phillips.
Thank you, and thank you, Ms. Bender. This has been a terrific presentation and effort. I just wish that your organization took a leap beyond hospitals and looked at doing some quality evaluation of other ambulatory care settings. Maybe
We're working on that now.
in the future.
2018.
Great. Because more and more care is migrating outside of acute settings. And I have a question. You mentioned patient safety organizations. Here in Maryland, we have a Maryland Patient Safety Center. And let me just ask in the audience, is there anyone here representing or from Maryland Patient Safety Center, the Maryland Patient Safety Center? That's unfortunate. This is a nonprofit that works in Maryland. It is the Protective Medical Review Committee that is established actually by this commission for a number of years going forward, was redesignated as our state patient safety center, I guess in 2014 for a couple of years going forward. And I'm first of all disappointed, and I'm like that as a matter of record, that they're not here to hear this presentation, and maybe they will have some hopefully there will be some interaction between Leapfrog and our state patient safety center, which is the convening body under some cloak of confidentiality between hospitals to get their safety efforts improved. My question is whether or not you've seen nationally any correlation between states' overall grades and a particularly active or robust state patient safety organization.
We have seen that in the state of Florida. There was some work done by the American Hospital Association with us to look at to look at a pattern that we were seeing of improvement in Florida, and they had been very, very active with their patient safety organization as well as what's called the Hospital Improvement Network. It's HEN is the acronym, the bizarre acronym, but they had done a lot of work there. That's the one example that I know of, but we do think that those are very promising efforts. So, and I know about the one here in Maryland, and I think we met with them. We actually provided them with the grades in advance so they could take a look, and so we're more than happy to work with them as well.
Great, thank you very much.
Yes, Commissioner Metz.
Thank you, Ms. Binder. My question, not so much a question, but a statement more for the commission. Obviously, we value the data Mrs. Binder's group has given us and compiled. What is our next step? I mean, I'm sure the hospitals see this. I know that Western Maryland, as Ben pointed out to me earlier, I'm sure the Western Maryland Health System's happy they got a B. I'm sure they're ecstatic, and I'll read about it in the Cumberland Times, and it'll all be good. But
Western Maryland got a D.
Yeah. So, but what as a commission then are we going to be doing to encourage or develop some type of mechanism to disseminate information to our hospitals along the lines of consulting organizations or whatnot to help our hospitals within Maryland improve their grades? I think that's a question we probably should ask ourselves. The information's great, and for instance, when the health system, Western Maryland Health System, probably say, hey, we're doing great, we got a B, but I'm sure they'd like to have an A too, but maybe we could offer some type of assistance and guidance anyway. Thank you.
Well, first of all, I think that that's an excellent point. I think what we want to do is try to provide as much guidance as we can. I mean, obviously, one of the things we're doing is we're putting this on the website and making it very, very publicly available. I mean, that's what we're trying to do. And I think in our interaction with hospitals, and we have a lot of interaction with hospitals through our regular regulatory role, certainly we can reinforce this. I'm not suggesting that we, incorporate this into the standards for a certificate of need or anything like that. But I think we can play an educational role, and I think we're already doing that. This is the first time, actually, we've had a public meeting on this. But let me tell you this, Commissioner, I'm open to anything as far as, what we can do to promote quality performance improvements in Maryland. That's why we're all here. And that is why we decided to incorporate the efforts of the Leapfrog group on our website. But, as far as suggestions, speaking for myself, and of course others here may have other observations, but speaking for myself, I'm prepared to do everything we can to do this. We have very broad authority, regulatory and administrative authority, and I guess the question is, how do we use that?
Mr. Chair?
Yes, Commissioner Thomas.
The fact that we can have accredited hospitals in this state that have an F or a D or something other than an A should give us pause simply to kind of calibrate what we're measuring and what we say we're measuring. And, not to get into an academic exercise, but that's what could happen if we don't have confidence in the underlying methodology. So Leapfrog is one of many groups, and but I would like to think that if a hospital, either from a grade, for whatever reason, said they needed help, that we would be a resource to help them. And so at the Hospital Safety Center, I know they're not here, but I want to hear from them. How's this possible?
Right.
If they have arguments for or against, and just put it in context.
Well, I think that's excellent, and I think we ought to engage the Maryland Patient Safety. I think that's an excellent suggestion. But let me remind all of you, over the past year, our own staff, Therese and her group in particular, have started to give us data and information on the performance of Maryland hospitals. Now, I remember one particular meeting, I think it was about 6 months ago, that virtually everybody's jaw dropped when we found out that in certain areas where we thought we were just absolutely peachy keen, that we were actually doing very poorly. And the Center for Medicare and Medicaid Services ranked us at the very bottom when it came to hospital readmissions. Now, we made improvements, but I'm just saying, because we're in Maryland, we somehow or other think, we have this mental image of ourselves. We think of Maryland, we think, okay, we're a rich state. We've got a very, very high per capita presence of physicians. We're kind of like Massachusetts or Connecticut. And so therefore, we shouldn't be at the bottom of anything. But the truth of the matter is, in that one case, we were. We also found out from Therese and her colleagues that, for example, waiting times for emergency services are terrible in Maryland. We have made real improvements in hospital infection rates. We have done that, but we have a long way to go. So I know that this report is disheartening to a lot of us, but you had warnings from the staff. Everybody on this commission remembers this. We've had warnings from the staff that we are not what we necessarily have thought we were, and we have a lot of work to do. And so, Commissioner Thomas, I am absolutely with you. Whatever we can do to encourage improvement here in the state, we ought to do it. And that includes working with the Hospital Association, the Maryland Medical Association, the Patient Safety Center, whatever it takes. And I frankly think that members of this commission should probably talk about this among ourselves quite a bit, obviously in accordance with the sunshine laws and all that. But nevertheless, I'm sorry, but we got to follow the rules. It's hard for some of us, but but the point is, we have to start doing that, because I think this is a deadly serious business. I frankly was very disheartened when I saw the results. So I'm with you. I really am. Therese, please.
I also think it's important to note that HCAHPS plays a big role in this, and the results that you see. And Maryland hospitals we don't do well at all on HCAHPS scores, so we do have to work on that. And there's been work done with MHA and the hospitals, but we still have a long way to go there. So I think it's important to put that in there too. We've made great progress on a number of the infection measures, as you said.
Yes.
And specific hospitals with low grades have not made that same progress that we have as a state. So that's reflected in some of the grades. But I think HCAHPS is really a driver of this as well that we have to consider.
Yes, and Teresa, I want to publicly thank you once again for all of the great staff work you did over the past year to prepare us for this moment, because actually you were the one who sort of indicated to us we had some real heavy work to do.
Thank you, but if I could just also acknowledge my staff and our contractor, because they really, AGS, they've been a great contractor to help us through to support this, the Leapfrog project as well.
Right.
And we should also,
Mr. Director.
We should also acknowledge Courtney Carda, who was the interface with the Hospital Association and sort of was on the front lines in communicating what we hope they would do in collaboration with Leapfrog. So she heard many of the gripes directly and answered them fairly and with a good spirit. I don't think we should lose the fact that we made this happen, because the Medicare data that is used in other states is not adequate here in Maryland, and were it not for MHCC's work with the HSCRC hospital discharge data set, these scores would not be public today. One thing that, and we'll continue to do that until this CMS data is judged acceptable. I think that's an important contribution. I also think, and the question that was raised, is the Patient Safety Center here? The other question that should be raised is, how many consumer and employer groups are here? You don't have to raise your hand, but the strength of these initiatives in other states has been driven to a great extent by employer coalitions. We have worked closely with the Mid-Atlantic Business Group on Health, but we need to buttress and reinforce our engagement with employer groups who evidence shows providers pay a lot of attention to. And here, I think there's been some complacency. The state's doing it all. We have this rate setting system, and we don't need to worry, is what I've heard employers say. We don't need to worry, and we don't understand it. But as we move to the next stage of the demonstration, as we move to total cost of care, these issues are going to become more important, and consumers are going to have a lot more at stake. And we haven't yet figured out what the winning formula is for engaging patients. We have lots of very positive, and I think I would give hospitals credits here for efforts they've made to engage patients in managing their care, but we still have a lot of work to do. And the success of this model is going to depend on not, as we have historically experienced here in Maryland, patients not even knowing. We're going to succeed if patients understand and take a proactive role in the care they receive. Certainly beyond patient safety, that's going to be a very important effort over the next decade should CMS sign on to this total cost of care contract.
Commissioner O'Grady.
I'd like to just throw one idea into the mix here. It strikes me that it's just trying to put myself in the position if I was hospital leadership, and I'd so this helps me in terms of if I've been trying to improve things and I have my board of directors is dragging their feet or something like that. And so this is actually helpful to the internal allies trying to improve things. And they probably have their own short list of, damn ERR, guys are letting, whatever. But I do think this is sort of an important thing of what are these other states that, what is best practice in terms of making this change? So if Rhode Island kind of goes from middle of the pack to first, or Virginia, I'm going to take a wild guess that they weren't always looking as nice as they do right now. And that may be something where there's a role either for the commission staff or for this particular group that is absent today, that just that sort of going back and putting together some sort of informal survey of states that have made big improvement and talk to this, kind of a Yelp, if you want to think about it, for people who have been able to help kind of improve. And do they give them 5 stars? Do they give them 2 stars? It was a waste of money? Or was this something that really they came in with a fresh set of eyes and gave us ideas we wouldn't have come up with ourselves? Right. So that's something that without being overly regulatory or overly mandating anything, but they probably, each of these individual hospitals don't have the resources to do that sort of consumer review, right. Each one, starting from a blank sheet of paper. And I would get to Commissioner Thomas' point before. Having been through a lot of these things of arguing over the methodology and kind of trying to refine it, you always want to refine it because you don't want to miss things. But I've never in my 25, 30 years of that, I've never seen somebody go from a D to an A. You can go from a D to a C, an A to a B, but these are all good things to bring up, and because I'm sure your product can always be improved because everything we all do can always be improved. But it's not night and day. It's not going to take an F and make an A or even a B. So and the danger with kind of getting too much into the methodological kind of underpinnings and sort of burning, you lose time. And it certainly is, people who want to stonewall these things, going to methodology is almost always the first arrow they pull from the quiver. So you don't want to be any kind of implication you're doing that. But I think at the same time, if there's things that come up, if there are real methodological questions, they should be discussed. But that's not a reason to slow up.
Right. Are there any further questions? Ms. Binder. Yeah, we talk a lot. Ms. Binder, thank you very much, and thank you for your work. Yes, yes. Anything here? No, okay. Thank you very much.
Thank you all.
Right, bye now. Our next item is a certificate of need case, Bethesda Chevy Chase Surgical Center. Okay. They've applied for a certificate of need to establish an ambulatory surgical facility. They want to establish themselves as an ambulatory surgical facility by adding a second operating room. And Bill Chan is here to present the staff recommendation. Bill, it's up to you, man.
Okay. Thank you, Chairman Moffett. Commissioners, good afternoon. Bethesda Chevy Chase Surgery Center is an existing physician outpatient surgery center performing orthopedic, neurosurgery, and pain management services with one operating room and one non-sterile procedure room located at 66931 Arlington Road, Suite E in Bethesda, Montgomery County. The Commission issued a determination of coverage to establish this physician outpatient surgery center on September 20th, 2010. Bethesda Chevy Chase is owned by Surgical Center Development No. 3, LLC, and by 16 physicians and one single physician-owned LLC. The center serves patients from Montgomery, Frederick, and Prince George's counties in Maryland, and those who reside in Washington, D.C., and Northern Virginia. The proposed project will renovate an existing procedure room at Bethesda Chevy Chase to create a second sterile OR. The center has leased additional adjacent space to create a replacement procedure room. Upon completion, the facility will have 2 operating rooms and 1 procedure room. The primary drivers for this project are the current demand for surgical procedures and the projected increase in the number of credentialed providers. The total estimated project cost is $1,759,618, which the applicant will fund with $620,000 in cash and about $1.1 million in the mortgage loan. The project will take 6 months to complete. As a physician outpatient surgery center, the center had no obligation to provide charity care. However, Bethesda Chevy Chase financial records indicate it provided charity care as a percentage of total operating expenses in the amount of 0.46% in 2016. The applicant states a commitment to provide charitable surgical services to indigent patients at a level that is at least equivalent to the average amount of charity care as provided by Maryland ambulatory surgery facilities in the most recent year reported. In 2015 was 0.46%. To address needs, the applicant must demonstrate that the existing OR was utilized optimally over the past 12 months and that the expanded 2 OR capacity is likely to be used at optimal capacity or higher within 3 years of project completion. Bethesda Chevy Chase operated a single OR at 154% of optimal capacity in 2015 and 142% of optimal capacity in 2016. The center expects to maintain a utilization level sufficient for both ORs to meet optimal capacity by 2020, based on the addition of providers and an expansion in the number of insurers with whom the facility and its providers will be recognized as in-network. The alternatives considered and rejected by the applicant were: 1, extended hours of operation. The applicant's patients, staff, and physicians do not like to be treated or to operate at hours significantly outside of the center's operating hours, which is typically starting at 5:30 a.m. to 7 p.m. in the evening. Extending hours will require the applicant to pay additional overtime or require hiring additional staff. The second alternative was relocation to another site. The applicant was unable to find another site of adequate size in the same building, and the cost to construct a new facility was estimated to be more than $2 million, which exceeds the cost of the proposed project. Staff concludes that the applicant has made a reasonable demonstration that the decision to renovate and convert an existing procedure room into a second OR and construct a new procedure room is the most cost-effective alternative. The center will finance the project through cash reserves and a mortgage loan. Bethesda Chevy Chase submitted a letter from the independent accounting firm of PKS and Company attesting to the availability of sufficient cash reserves for the equity portion, and a letter from SunTrust attesting to the bank's interest in the debt financing component. With regard to impact, Bethesda Chevy Chase does not anticipate a significant shift in surgical cases from hospitals or other ambulatory surgical facilities to the center. This project will allow the center's surgeons to schedule surgical cases during normal business hours and will meet existing patient and provider volumes. The project will not have an adverse impact on the healthcare system's costs or the cost of care. To summarize, that concludes that Bethesda Chevy Chase project complies with applicable standards in the General Surgical Services chapter of the State Health Plan, and the application demonstrates needs, is financially viable, is a cost-effective approach to meeting the project's objectives, and will have a positive impact on the applicant's ability to provide outpatient surgery without adversely affecting costs and charges or other providers of surgical care. Staff recommends the Commission approve Bethesda Chevy Chase Surgery Center's application for a certificate of need, authorizing the establishment of an ambulatory surgical facility by converting an existing non-sterile procedure room to a second sterile operating room and construction of a procedure room using leased space. Before questions, if there are any, on behalf of Bethesda Chevy Chase Surgery Center, I'd like to introduce the following individuals. First, Mr. Seal Coley-Gale, who's the administrator of Bethesda Chevy Chase. Mr. Ian Friedman, who's the General Counsel of Surg Center Development. And then there's Senior Counsel Jack Ellis.
Welcome.
That,
Welcome. Thank you.
I open the table.
Sure. Mr. Chan, thank you very much. Any commissioners have any questions for Mr. Chan? Yes. Commissioner Phillips.
Very briefly, thank you for your review and staff recommendation. Something that you said caught my ear, which is to say that there was no expectation that this increase in the capacity, the OR capacity, would be reflected in any transfer or shift of patients from hospitals to this new facility. And I'm not paraphrasing what you said. You said it much more elegantly than that. But so that suggests to me that, well, if it's not a shift of patients, then there's more demand. So where is?
Well, right now they're using one operating room, and obviously they're extending their hours of operation. Currently, they have 16, maybe 17 physicians, plus they are going to add 2 orthopedic surgeons, which I didn't mention. So they're increasing the number of physicians who have privileges and will use the facility. And right now, the capacity is just, it's difficult for them right now to meet the capacity for all 19 physicians. So that's why they're submitting their request for the second OR.
They'll have more cases though, right?
Yes, please.
And those cases will come from?
From the existing patients who presently are served by these physicians, these surgeons.
And they're served by these physicians in other facilities?
The 17, as I'm aware of right now, are using Bethesda Chevy Chase. The 2 orthopedic surgeons that are being added, they, I think, serve a minimal number of cases in Northern Virginia, and that's not going to have a significant impact on the hospitals or ambulatory surgery centers that they currently, or they previously had privileges at.
So, I don't know. Are there patients?
The population is growing every day. The number of
Right.
people who need surgery is
Getting
growing
older
every day.
Right.
The existing capacity within the hospitals is not growing at all. So there has to grow somewhere. So it grows in surgery centers largely. And what's happening to some extent is some outpatient surgery that's currently being done in hospitals being shifted to surgery centers, to a much lower cost environment.
Right.
And the increase in the hospital space is getting backfilled with more appropriate care.
Right, but that's not what we
Things like
heard.
joints.
We heard that nothing was going to change,
That can't
but
be
you're going to add.
Right.
You're going to add capacity, but there's no more demand, there's no more cost.
Which,
At a macro level, that's not possible.
That's not possible.
One at a time. Okay. Mr. Friedman, yes, you come to the table and clarify this before I lose control of this commission.
Sorry, I think the key was it was not a material shift from the hospitals, that we wouldn't be taking cases that would impact anyone. Clearly, more cases will be coming as there's more capacity. I think what Commissioner Pollack said was correct. You know, these are physicians who currently, I think for almost all of the members and people credentialed here, they operate at a hospital and this surgery center. And currently, they are doing cases that would be eligible for the surgery center at the hospital simply because the surgery center doesn't have the capacity. And then, as Mr. Chen mentioned, we have these two new physicians who are operating in hospitals outside of Maryland who are moving to the area. So it's just not an impact on any existing.
Right, it wasn't a loaded question.
No,
I just wanted to understand where did it all come, where did the basis come from?
So your question made sense. And just to clarify.
It's wonderful when questions make sense. The director has a
No, I think Mr. Chen's point was that given, you know, when we do consider these questions, there is the issue of, well, the hospitals are on global budgets, and he stated it in the context of that these volume gains at the ASC would not come as a result of draining off additional volume from the hospital, and that's the way we ought to look at it. I didn't view it as so narrowly as there would be no volume gain. My expectation is that this facility, should the commission add another ASC, is going to do more cases. Is that correct?
Yes, they will do more cases with this new OR.
So the neighborhood hospitals may see a drop off, but you're saying that nothing will be considered significant or threshold level.
I can guarantee you that no hospital will notice any drop off in what they are doing.
All
In
right.
other words, you don't have to really worry about a lot of.
But when we think in aggregate, then part of what you're making is that that there is a potential. If this amount of utilization was going to happen anyway, you're taking a certain percentage, not enough to worry them, but you're taking a certain percentage then and doing it in a lower cost environment. That the net effect here is potentially a savings over baseline of what might have happened with no change.
Yeah. In our experience, most of the hospitals welcome this expansion because these are cases that are taking up time in the hospital that could be better used for more serious cases that aren't outpatient eligible.
Commissioner Pollack.
So I hear in some of the comments and responses that there's a concern that we're here to protect the hospitals and protect their volume in these cases. And I think for many of us, I'll just speak for me, but the concern is just the opposite. If there are cases that can be done in an outpatient setting like yours, they should be done in that outpatient setting like yours, because the cost is approximately 1/3 of what it would be to do those cases in the hospital. We encourage those cases to move out. If the hospital can't backfill it with appropriate surgery, then shame on them, and they should lose part of their GBR for it. But that's okay. The idea that somehow you're taking volume from a hospital isn't something you should have to apologize for or prove it isn't going to occur.
You'll have to forgive Commissioner Pollack. He's obsessed with free market efficiency, and you know he lives in an environment in which that is so rare. So, Mr. Friedman, be kind.
I appreciate it.
Just to add one point also, which I didn't provide earlier, was that I think the number of insurers who are in network at Bethesda Chevy Chase has increased as well. I think they've added not only Aetna and Cigna, and I think some of the other providers. So there are increasing cases. More of the cases are moving towards outpatient ambulatory surgery. The insurers are obviously encouraging it, and I don't think that there would be a significant adverse impact on existing hospitals' utilization.
Yeah, we do have, just to go to your previous conversation, very low infection rates, you know, because we don't have to, you know, we take people who can be in an outpatient setting, so it's a safe place for surgery. And I think you guys have it. It's not going to impact the hospital.
We're very happy to hear that.
I'm going to be quiet.
Okay.
Which is a hard thing for an attorney to do.
I know, but you're representing a client, and you never know how these things go. Are there any other questions? All right, the action here is to approve the certificate of need for Bethesda Chevy Chase Surgical Center. Do I have a motion? One motion. Do I have a second? Second. All those in favor say aye. Aye. Nobody opposed. Mr. Friedman, Mr. Eller, Ms. Calivio, right? If I got it right? Right. Thank you very much. You have your certificate of need.
Thank you all
Thank you.
very much.
Bye now.
Much appreciated.
Right. Okay. The next item is a change in the approved certificate of need for Suburban Hospital. In May of 2016, the Commission approved a CON to modernize Suburban Hospital. And that CON included the construction of shell space designed to accommodate replacement nursing units in the hospital for the future. Suburban now requests authorization to modify their previously approved CON to build out the shell space and to make other design changes to improve the efficiency of the hospital, the layout of the hospital. Kevin McDonald, who's our chief of the Certificate of Need Division, will provide the staff recommendation. Kevin, the floor is yours.
Thank you, but that's going to be a hard act to follow. Good afternoon. As Mr. Chairman described, this is a CON that was approved in 2016, May of 2016, for $200 million. The centerpiece of that project was a modernization of the hospital, particularly creating private patient rooms and modernizing the ORs. As the hospital proceeded with bidding the project and further planning, they were pleasantly surprised by favorable bids and thus have approached us with this proposal to modify the project. And they are before us because the cost would exceed the inflationary allowance that is built into their CON. So what they're requesting is to accelerate the build out of that shell space. And they would fit out 2 nursing units on the 3rd floor, totaling 54 patient rooms. They would also be relocating the cardiac cath laboratory and making some other modest changes throughout the hospital or throughout the proposed project that would increase the efficiencies and the adjacencies and flow. In reviewing the project, staff does not believe that the requested modifications would have had an effect on the findings made by the Commission back in May of 2016. Looking at our criteria and how this modification would affect it, in terms of need, there really was no change in the nature of this project. So the need criteria really doesn't come into play. In terms of viability and financial feasibility, the capital is available. On the operating side, the increase in the project costs will not hurt operating results because the hospital has actually changed its financing a bit, reducing the interest expense to the point that their total operating expenses are actually projected to be lower than they were in the initial proposal. In terms of the cost effectiveness of alternatives, I think the hospital has made a credible case that the centerpiece of this modification, accelerating the finishing out of the shell space, is a better alternative given the favorable bids that they've received and their ability to cover the additional cost with cash. They estimate that they will save anywhere from 15 to 25% on that build out by doing it now rather than doing it later. And the balance of the modification, such as the consolidation of the cath labs into the surgical services area, relocating the supply chain services in the cellar of the project, and the more modest modifications of that nature, will improve the operational efficiency and provide better campus access. In terms of impact of this, that this project would have on the healthcare system, similar to need, the nature of this project isn't changing. So we found previously that there would be really no impact on other facilities, and believe that that would still be the case. And because there is no increase in the GBR requested, no impact on cost of services. Accordingly, staff recommends that the commission approve the proposed modification with the conditions that are listed in the staff report, essentially related to the use of the patient rooms as private rooms only, unless MHCC authorizes otherwise. Limits on the use of the second floor shell space, which was also in the original CON, and limits on the request for rate adjustments related to the use of shell space and excess construction costs compared with the MBS estimating system. Here to represent Suburban is Joe Lindstrom, who is the Vice President of Operations for Suburban. Ann Langley, Senior Director for Health Planning and Community Engagement with Johns Hopkins Medicine. Spencer Wildonger, Director of Health Planning for Johns Hopkins Medicine. And the ubiquitous Andy Solberg.
Okay. Thank you very much, Kevin. Commissioners, any questions about the application?
I had one, and it's actually really more about the conditions that relate to the HSCRC and the rate setting in the future. And I was hoping you could explain one of the issues that we're having to deal with is the extent to which we overlap with the HSCRC, if we do. Is anything in these conditions something that they also will be evaluating, or is this independently something we've set, we put these conditions in place, they just apply them, and it's being efficiently handled? I'm trying to, it's not really about this application as much as how these conditions would work.
Well, the condition is if Suburban does at some point feel that they need to make a request to increase their GBR to finance this project, what the conditions in here are that any remaining shell space would not be eligible for that kind of reimbursement because it's not a rate regulated activity. And the other is that there is, according to the estimates that are done on the comparison of costs, there is some excess cost in this project.
Yeah, I guess,
and that would not be eligible for reimbursement. And at this point, those may be moot points because they're at this point they're not planning to ask for that, but they do reserve the right to do so in the future.
But I guess my question was really more about dividing what the HSCRC does and what we're doing. Is the HSCRC just taking these numbers and putting in its rate setting, and there's no chance, there's no point at which they have to go and make these showings again because we're handling this aspect and we've done it definitively and it's finished? Or is there something where we've proposed these conditions, the HSCRC does another analysis, they kind of overlap? That was my question.
I don't think they do any other analysis. They take these conditions and they implement them.
Thank you.
Commissioner O'Grady.
Just to follow up on that line of logic. So this is when you say that they agree not to ask for any additional rates. That's the taking the pledge, as we've referred to in others, or is that something?
No, taking the pledge would have enabled them not to have to approach the CON process at all.
Oh, okay.
But they are not requesting, as part of this project, they're not requesting an increase to their depreciation.
Got it.
In their rates.
So that means that, but if they make a commitment to us that they won't come back and ask for a rate increase related to this particular project, is that binding then in terms of anything beyond their dealings with us on CON? Is that binding to the other commission?
In a scenario where rather than doing this CON, they had asked for determination and taken the pledge, we could have allowed that, and HSCRC would then, if
if they came forward and asked for more money, HSCRC would say, no, you've taken the pledge, there's no money there for you. Now, if they were really up against it, I'm not sure what would happen in that case.
Right. But the mini pledge they've given us, that doesn't, how binding is that?
They haven't, well, they've simply stated in their application that they're not asking for more money in this.
But they reserve the right in the future.
But they reserve.
Right. So we have not made a pledge, we haven't made a mini pledge.
Yeah.
We have not made a request with
Right.
this. We are not currently in negotiations with the HSCRC over a rate increase that includes this project.
Okay.
That's all we've said. That's what's true.
Got it. Okay. So you reserve your right in the future, but this is looking like a good economic opportunity for you because
Well,
you have the money, the bids came in lower, and you can go all the way rather than do it in pieces.
so this modification, I mean, this project is huge for us. It's been
Yeah.
10 years in the making. We've funded several lawyers, children through college.
Right.
See our zoning.
Summer home,
I
the whole
mean,
thing.
yeah, so,
Right.
and this modification is a very small piece of what we're doing, and all it is, I mean, the real kernel of this is it's a lot easier and less expensive to fit out these units now. That's why we're here. All the rest of this is part of the process because we're doing that, and it takes us just over the amount we're allowed. That capital increase brings us in with a full application for this full review. But
That's clear. Yep.
Thank you very much,
Thank you.
Ms. Langley. Any further questions? Okay, no further questions? I have a motion to approve the modification of a certificate of need for Suburban Hospital. Okay, second. Okay, all those in favor, say aye. Those opposed? Congratulations. Mr. Lindstrom, Ms. Langley, Mr. Wolbunner, you have your, and Mr. Solberg, of course, you have your certificate of need. Thank you. Okay, the next item has to do with the acute inpatient rehabilitation services. This is an emergency and proposed regulation to the state health plan. Dr. Pollack is recusing himself. The commission staff is requesting that the commission adopt emergency regulations that amend COMAR 102409, the state health plan chapter for acute inpatient rehabilitation services. Paul Parker, Center Director for Healthcare Facilities Planning and Development, is going to present emergency and proposed regulations for the state health plan for specialized health services, the acute inpatient rehabilitation services. Paul, thank you very much.
Thank you, Chairman Moffett, members of the commission. So we are seeking, as the chairman said, emergency changes to these regulations. This state health plan chapter is for acute inpatient rehabilitation services. So just to make sure everyone understands what we're talking about here, these are hospital level rehabilitation services. The typical patient population would be someone perhaps with head injury, spinal injury, a severe stroke, other types of traumatic injury, someone who needs high acuity rehabilitation services, typically a multidisciplinary approach toward rehabilitation. So it is a specialized service. Most hospitals do not provide this service. It's regionalized in terms of its distribution throughout the state. We have some special hospitals for rehabilitation. We also have general hospitals who have acute rehabilitation units. So our state health plan was updated to cover this service in 2013. So it's not an old plan that is out of date. It's still very serviceable. And when we developed that plan in 2013, of relevance to what we're talking about here, we developed a bed need methodology. which had not been present in these regulations before. We had used for many years an approach that became very outdated that really just looked at occupancy rates. And we realized in 2013 that we were going to have some issues with data sources in terms of this bed need projection methodology, because at that point we knew we were going to be making the changeover from ICD-9 codes to ICD-10 codes in the near future. And we actually tried to account for that in the way we wrote that plan back in 2013. So the section of the plan that we're looking to amend here actually allowed us to change the coding when that became necessary in order to come up with accurate counts of acute rehabilitation patients and measuring their use with the discharge databases that provide this information to us. What we realized, and we first started realizing this about a year ago, when we started looking at updating our bed need projections for acute rehabilitation, is that we really need to look farther afield from just changes in coding in order to establish accurate information to use in the bed need projection model. So this is a fairly technical amendment. In the memorandum that you got from Eileen, in the appendix to that, we provide you with the new section E, and it has four paragraphs essentially, and it's replacing, a 2-paragraph section on data sources that was in the 2013 plan. And the reason why we feel like we need to do this fairly technical change is, again, because in order to get an accurate count, it's now not just a matter of inserting different CMS diagnosis-related group codes. We're having to use different data fields in the discharge databases, the nature of admission field and the type of service field. So we do have some urgency in terms of wanting to go ahead and accomplish this update in our bed need projections. We feel like in the past year we have worked with HSCRC and with some individual hospitals in order to get the information that we need to do that update, so we're ready to go out with it. But we wanted to make sure we had an accurate description of what we are currently having to use as our data sources and how we have to go about counting these types of patients so that there would be a complete and fair understanding by the field of exactly what data we were using to do the updated forecast. And as Eileen mentioned in her memo, we do anticipate getting an application in 2018. And it will actually be the first substantive use of this 2013 chapter. We anticipate getting an application for a special hospital for rehabilitation in the Southern Maryland area. So we want to be in a good place to review that, and that's why we're here asking for the ability to amend this information on data sources on an emergency basis. And in closing, just to make sure everyone understands how this works, the emergency status that we're asking here really just means that these go into effect now, and we can go ahead and proceed and safely do this change in our bed need projections, update in our bed need projections. These regulations will go through the usual process of a comment period. We'll be looking at those comments, looking at whether we need to make any further changes, and then we will be back to you as soon as we can get through that process with regular adoption of these changes in the regulations. And that's all I have to say. I'll be happy to answer any questions if I can.
Okay. Thank you very much, Mr. Parker. Any commissioners, any questions at all? Yes. Commissioner O'Grady.
I mean, it certainly sounds reasonable. I'm only confused by why this is emergency versus this is just, somewhat expedited in terms of, is there something else? Is there a shorter comment period? Is there anything along those lines that would indicate that makes this emergency versus this is the first one we want to handle because we want to be ready when the CON application comes in?
So, I want to ask, if I may, for our attorney to sort of clarify, this matter a little bit, but.
So, if the recommendation of staff today is that you adopt these regulations as both emergency and proposed, AELR will still have the opportunity to say, you can't go emergency. But the reason it's important is because we need to have the proper data sources and regulations before that CON review takes place, or the decision could be subject to legal challenge.
Thank you, Counselor. Any further questions? Okay. The action is to issue emergency and proposed regulations for acute inpatient rehabilitation services. Do I have a motion? Motion. Do I have a second? Second. All those in favor say aye. Those opposed? Very good. Thank you very much, Paul.
Thank you.
Okay, ladies and gentlemen, each November, the Commission formally adopts an update of the medical care database manual for the coming year, the MCDB. The submission manual is designed to provide designated reporting entities with the technical specifications, the layouts, the definitions, all the necessary format for filing the reports that are required under our regulations, COMAR 10-1506. Several minor changes are planned for 2018 to make the information more useful for the public, and cost analyses also that are going to be conducted by the Commission, by the HSCRC, and the MIA. Ken Yates Trotman, who's our Chief of All Payer Claims Database, is going to present the updates for the manual. Ken, thank you for coming. Well, the floor is yours.
Thank you very much, Commissioners. I'm going to give a brief overview as to what I will talk to you about. I'll give you a brief refresher on the MCDB reporting requirements, and review the changes of the 2018 data submission manual, and seek your approval of the manual. What is included in the MCDB? In terms of commercial data reporting, we get information from life and health insurance carriers and HMOs, TPAs, PBMs, and behavioral health administrators. We also get information from the qualified health plans and the qualified dental plans. In terms of the type of data that is reported, we have the membership in terms of the eligibility file and claims files in terms of professional services, institutional, pharmacy, and dental. We also have a provider directory and a non-fee service spending, which is still under a testing phase. For the Medicare MCO data, we get that data from Medicaid via the Hilltop Institute. And for Medicare information, we acquire that through a state agency DOA with CMS. What is changing in the MCDB for 2018? There are no changes in Maryland's reporting requirements, except for the following reminders. We want to remind payers that facility claims, those are claims received on the UB04 forms, for all freestanding centers, including ambulatory surgical and radiology centers, shall be reported in the institutional services file. The Commission shall assess both the quality and completeness of data regarding services provided at these facilities. And we want to remind payers that they shall perform data quality checks before reporting all data to the MCDB portal. We have a few fields that we will add to the MCDB. We have the mail order pharmacy indicator, which is added to the pharmacy services file. And that replaces previous paper reporting. We also added the units of service and service unit indicator to the institutional services file to parallel the professional services file, since the institutional services file is now on a line level format starting in 2016. And lastly, we added the place of service field to the institutional service file to align with the Maryland Insurance Administration. In terms of carrier feedback, we had no negative feedbacks or negative responses on these changes. And we continue to promote timely data submission by clarifying reporting final date requirements and validation checks. And we aggressively enforce our finding authority for seriously because delinquent payers reporting to the MCDB. In terms of next steps, we will ask if the commissions have any questions and to ask for your approval to post the submission manual to the commission website. After that, we will disseminate the manual and follow up with payer meetings and implement these changes starting in May 2018 for the first quarter of 2018 data.
Okay. Thank you very much. Commissioners, do you have any questions? Commissioner Fleet.
I think I might have heard your answer and read into it, but you talked to all the carriers before this is being posted?
Yes, we have sent out the manual for payer feedback, and we have some feedback, not from all carriers, but we had some feedback as well.
So what does that mean from not all carriers? They just didn't answer?
They just didn't answer. They just didn't respond in the time frame that we allowed them to respond.
Okay, thank you.
Any further questions? All right. The action before us is to approve the release of the data submission manual updates. Do I have a motion? Motion. Second. Second. All those in favor, say aye. Those opposed? Thank you very much.
Thank you.
Thank you. Sure.
This seems to me to be the kind of duty that is well within the judgment of the executive director. Is there something, I mean, is there something that it needs commission approval rather than?
Very good question.
Once Ben thinks it's ready to go, it goes?
So in our current regs, it does call for the commission to approve action. And I believe the rationale for this was that we avoided the insertion of the actual data specification in regs, which would be even a more cumbersome process coming through what was classified as an abbreviated process. Our regulatory oversight authorities felt this would be acceptable. If we passed this on to my authority, it probably would go back to the question of, do the regs have to be changed every time we make these small reg format changes in what the payers are required to submit? But we can check on that again to see if that's still the opinion of our AG.
I think the idea is that there's a general rule that an agency puts out that needs to do it by regulation. And what we're doing in this case is, since we're approving this, we don't feel the need to put out a regulation for these general rules. That's sort of a summary.
The commission's regulations provide that it can be done this way, and it is interesting in that it has a regulatory promulgation-like process, because these changes are posted for informal comment if anybody wants to comment before it comes here. And so this just keeps the commission from having to go through a long process every time it changes it, and this is changed every year, so it adds at least 6 months to everything. And this worked. It may be unusual, but it works, and it's good.
Okay. And I guess, in that idea of kind of administrative simplification and keeping the bureaucracy to its essence.
Right.
The same thing with what Paul came, I mean, is that not something that, again, instead of true criteria for data, we're going to use 4? Is that not, again, something that could get this sort of fast tracking rather than
Well,
him having to do
Not under
emergency
this
and,
circumstances. That's because the current rehab chapter specifically provides what the data sources are. That's in regulation. Now, the new wording does give more flexibility. For instance, it doesn't talk about, I don't know, later changes to DRG numbers like the earlier one does. This is more specific and does give more flexibility for the commission to obtain the precise, correct data that it needs to do bed need projections.
right. It just seems that with the evolution of data and both not only in what's collected, but your ability to link them, et cetera, that this notion of having to come back to the commission Paul looks next year and goes, we really ought to be incorporating the new CMS file on ACT. It just seems cumbersome that okay, well, let's see if I can get on the docket. Let me see if I can come in between this CON and that CON. I'm just thinking these are, I understand the due process and there's a time for people to comment, et cetera, but it does seem overly cumbersome in terms of the staff being able to do their job.
I think you raise a valid point. I think that's, we're trying to operate under the guidance that the attorneys provide in the statute itself. But I do think you see sort of the back-to-back today. You saw what are the two alternatives, and I think what Ken presented to the manual is actually a much easier process, assuming that we don't change this every year, that because this is evolving even as we speak, the demands from the Maryland Insurance Administration and HSCRC regarding what we collect change, we could actually anticipate putting a data specification in health plans that are consistent with what's being done for the MCDB, and it probably wouldn't change every year. The MCDB specifications change because data, it's a very expansive data manual, and what's being collected changes even in a minor way. It's the advice of our counsel that we have to bring it back to you. If we didn't change it, we wouldn't come before you.
And if I could, the reason you also want a manual is that the people who are doing the data submission are not the legal department in any of these carriers, and they're not reading regulations. So giving them a manual is something that they're going to be able to pick up and read. So there's also a more effectiveness nature to that. Take Commissioner O'Grady's point, though. I think as we look at chapters in the state health plan, it's a very legitimate question to when you get to the part of saying we should use DCRG codes to prove this and not those DRG codes. Is that a level of specificity that needs to be in the regulation, or is that something where better to say these are the things you have to prove with credible evidence, and is that sufficient? I think that's a good question as we come up with new chapters to say how deep does the regulation have to go and how much discretion can we?
I think if you look at the rehab regs, the changes, you'll see that it has become much simplified. Also, the commission's doing that more and more. If you look at the home health agency chapter, the performance guidelines that will be considered in CON reviews are adopted by the commission, but they're just published on the website. They don't go through the regulatory process. First is comment, then they're finally adopted by the commission, not as regs, but just as the guidelines. So it's happening more and more by the commission. It's made the process of doing this.
Mr. Director?
Yeah, I think your point is a good one. As we look at the CON work group, that's an area we want to look at. If there's other areas for further modernizing processes, we should.
Okay, so that's it. Next item is the Maryland Physician Services Trauma Fund report. Back in 2003, the General Assembly enacted legislation creating the Maryland Trauma Physician Services Fund to help the trauma system by reimbursing physicians for uncompensated care losses, and when they're giving patients care in these centers. At that time, the Medicaid payments were 100% of the Medicare rate. Some of you know the trauma fund generated a fund balance largely because uncompensated care payments have declined. It appears that one of the major contributors of that decline has been Medicaid expansion. So 2 years ago, the Commission voted to raise uncompensated and on-call payments for trauma care to 105% of the Medicare rate. Last year, we asked the staff to include recommendations for reducing the fund balance. This year's report contains those recommendations. It contains two sets of recommendations. What the Commission can do itself under its regulatory authority, and also includes the kind of changes that the General Assembly could adopt. Bridget Zombro, who's our Director of Administration, and Karen Rezovac, Program Manager, are going to present the report. Ladies, the floor is yours.
Thank you, Mr. Chairman, for that excellent overview of the highlights of our report. With that in mind, I'd like to tell you all a story. I promise it's short. I had a conversation a couple of months ago with the manager for physician billing at the university's practices, and we were discussing the trauma fund, questions that they had, and how she approaches training all the people that work doing billing. She said that when she explains how this works, she correlates it to the Building and Loan Association in Frank Capra's excellent film, It's a Wonderful Life. I loved it. I loved it.
Yeah, me too.
She said, if we don't take care of the fund and follow the rules and make reimbursements when they're due, the fund will go away. It is our version of the Building and Loan, and we are very blessed to have it because Maryland is unique across the United States in having a fund like this. So I love that story, and I promise to share it with you. So with that in mind, the fund was created about 10 years ago, as Chairman Moffitt explained. And Bridget, you're up.
I'm always going to talk to you about money.
Right.
So, the FY 2017 collections and expenditures, the fund received $12.4 million from the $5 registration fee collected by MBA. The fund expended $1.8 million in uncompensated care, $7.5 million in on-call and standby, about $140,000 to Medicaid, and $133,000 in administrative expenses. This leaves a surplus in the fund of approximately $10 million. Karen?
So as Chairman Moffitt noted, we believe causes for these lower expenditures are the distinct drop in uncompensated care claims paid over the last 2 years. Medicaid reimbursement has been below our expectations. Commission staff expect that this year that we're in, 2018 fiscal year, that there will be similar results. So we have taken a step to date to increase uncompensated care and on-call stipends to 105% of Medicare, as you know. And we would like to consider options for addressing the $10 million surplus. One is continue the 5% bump in the Medicare reimbursement. Secondarily, to expand trauma equipment grants. They could be made annually rather than biannually, increase the amounts of funding for each grantee. And basically that would be the change. We're just going to discuss other options.
We also included in the report 4 other options that can be considered by legislative committees because they require statutory change. One would be to lower the registration fee from $5 to $4 for the residents of Maryland. We could also ask that the MHCC be granted $500,000 of the balance of the fund to be used for telehealth grants. That can also help reduce EMS services in the state. Maybe provide higher reimbursement to level 2 and level 3 trauma centers. And, or we could, or they could increase the number of providers that are eligible for uncompensated care payments and Medicare underpayments. However, staff recommends that any use of the trauma fund balance be restricted to trauma and EMS first, and then other healthcare system needs second. This concludes our presentation. We'll be happy to answer any questions for you. We ask that you release the report.
Yes. Thank you very much, both of you. The most important thing that you said is what you didn't say. Well, you sort of said it. None of this goes into the general fund, right?
Correct.
Right.
Correct.
Very fiscally responsible of you. Thank you very much. Any questions? Yes, Commissioner Sargent.
I did have one. The reason why we have a surplus is because of the reduction in care from the Affordable Care Act, which would be the Medicaid expansion.
That's part of it. We think uncompensated care also is declining in the state.
And I just sort of looking at the options. I know we're not deciding today on any of these options, are we?
No.
Because I think I'd want to think long and hard about acting too quickly about relying on the Affordable Care Act at the moment. We might want to see how that shakes out. It's still the law, that's what but there are a group of people trying to make it not the law. That's what I mean. We may want to wait before we act one way or the other till it's less of a hot potato.
Commissioner Pollack.
Yeah, so we said last year we want to wait on it, and we did. And I would agree with Commissioner Thomas. I don't think that piece of it's going to go away, at least not in the state of Maryland. I can tell you that on the end of the people billing under the trauma fund, the issue is the Medicaid expansion. The uninsured have gone down in the trauma population almost exclusively because of the Medicaid expansion. That Medicaid expansion has created a problem for those billing under the trauma fund because of two things. One is the rate that gets charged. So theoretically, for even the Medicaid patients are supposed to be paid at Medicare rates under the trauma fund. They haven't been for a couple of years. They've sort of corrected that partially now, but the MAMCOs are still having difficulty meeting that guideline. The second is the Medicare billing rules that are used are different. CoreSource, who the Healthcare Commission has used to administer the fund, billed under rules that are directly consistent with the statute, which is that the bills get paid at Medicare rates. The MAMCOs don't do that. They bill at Medicare rates plus Medicare rules, which means that for multiple procedures, which is a lot of the Medicaid population, a lot of the trauma population, not the Medicaid, a lot of the trauma population, so they'll come to the operating room and get 2 or 3 things done because they don't break just one thing at a time. In high energy trauma, they break multiple things. They injure multiple things. Under Medicare rules, the first procedure gets billed at 100% of the Medicare fee schedule, the second at 50%, and each subsequent procedure at 25% of the Medicare fee schedule. CoreSource was reimbursing them each at 100%. And that's a big difference when it comes to 3 and 4 procedures in terms of the total amount. So the amount that was getting paid before the MAMCOs took over a big piece of this was much higher than the amount that's getting paid now. And that's, I think, a big piece of what we see as a much larger deficit. It's created a problem for the providers because the amount that the providers were seeing under this before is much greater than the amount that they're seeing now. I think we have to find some careful solutions to that problem, but I think what it means to me is that this structural surplus is here to stay. It's not a temporary thing. The second thing I would offer is that trauma and EMS are not the same thing. When the legislature enacted this, they recognized that this was an issue that related to trauma and to access to trauma care, and we needed to have the system in place to be able to preserve that access to trauma care. So I'd be a little bit careful about expanding it to EMS because that world is huge, and you will suddenly get, it'll be gone, and it'll be effectively just dumped into the general fund. So I think that level of caution is, that level of diligence is missing when you do that.
Commissioner Thomas.
So I would agree, Commissioner Sargent, we should take our time, but for different reasons. We should take our time because there are a number of issues that have come up that are beyond the scope of our resources to address. And this gives us a little more bandwidth, maybe, to give some thought to it. So we just had this leapfrog report. Let's take a look at what they said around trauma. And if there are issues around helping our hospitals do a better job, since we said that's one of the things we want to do. So I would just say we don't want to just limit it to telehealth. We want to be open to possibilities that maybe we haven't thought about before because we've never had the possibility or resource to even think about it. So that's why I think that the time and deliberation should be there. We've also talked a lot about racial and ethnic health disparities, certain populations that are not benefiting. So it could be something very targeted to keep some flexibility.
Yeah, Commissioner O'Grady.
I guess to Commissioner Sargent's point, and I think we just need to know, because we've talked about that this is mostly a Medicaid population that has caused the decrease. If the tax bill does take its current form with the removal of the individual mandate, that won't affect Medicaid, but it will affect the exchanges. And I just don't, so you might all of a sudden see the exchange population as premiums go up, kind of things drop, and that we probably do want to have some caution there about giving money back because we think we don't need it, and then 2 years from now we do. The other thing that I'd say, there's an implied policy logic. I don't think it's stated anyplace that the idea of adding something to car registration fees, that notion of trauma and automobile, and that sort of it's a user fee for the people we think may end up in the trauma center. So as we think about alternatives, I know you put on, well, take it down to $4 and that, or however. But I have a hunch that we will be more vulnerable to intervention by the Assembly the more we move off a policy logic that says we're going to tax drivers for a service that they're most likely to use, or there'll be a heavy group of users. And so I don't have that alternative that says, automobile crashes do trauma and X. But I would just keep in mind that there was, like I say, I don't think it's stated, but an implied logic that this is tied, that there's a reason drivers and people registering cars should be the ones paying this fee. And so if it just becomes our priority project, it's great for us, but it may be more, it's got a vulnerability in a policy related way.
I want to intervene here and ask both you and Commissioner Thomas, I guess, the same question. Are you suggesting that we delay the release of this report? I just want to know. Because, we could talk about all kinds of things that we could do. I think what the staff has done is outline a number of options that the state legislature could pursue if they wish to do so. And we could pursue if we wish to do so, and it seemed to be pretty broad. So I just want to make sure that we're clear about that.
Not to delay, just the things that were listed, including but not limited to.
Right.
That's all.
Yeah, sure. No, that's right. I just want to make sure we're clear about that. Are you clear about that?
Yeah, I'm very clear about that. I just wanted to add, I got right into my answering question without congratulating you on an outstanding report. I think that, thank you for your wonderful work. Yeah.
Right. Okay. Director?
So, I think this has been some useful discussion to guide the staff in thinking about this. I think that with a balance of $10 million, it will potentially be a target that could be used for other purposes. I think it's important that we emphasize trauma and it would be, to my thinking, EMS. I think that Commissioner O'Grady raised an important point that what other services related to motor vehicles and automobile driving are important. But I don't think that we're certainly not the ones in the driver's seat as the legislature begins its work in 2 months. So the ideas we put forward were just suggestions to the legislature, but I think being emphatic that applying it for health purposes, trauma particularly would be the first priority. The commission would be helpful to the legislature as they begin the deliberation. My other concern, and when we got this started, we worked closely with Chris Hogan to develop this framework, is that we've seen this pivot from 50-50 payment between uncompensated and Medicaid underpayment and on-call stipends. And as a result of the Medicaid expansion and the fact that many of the patients that are uncompensated back prior to 2014 are now Medicaid covered, we've seen this pivot in how the mix of the fund reimbursements are shifting increasingly to hospitals. There's been some discussion about should that really be counted in their GBR? As far as I know today, it is not. But I clearly think some thought about rebalancing this in an equitable way is something that we probably need to embark on and get some consulting assistance on. I don't think that stipends necessarily to practices that are delivering uncompensated care is the way to go, but I think there is a sort of misalignment when we are funding trauma capacity, which is what on-call stipends do. They provide payments to the level 2s and level 3s, which in the state of Maryland don't actually deliver the bulk of trauma services, but are needed and essential to the overall system because they do provide a share of it and keep the level 1s from completely being bogged down. But we have to think about how we balance this in a way that we're not jeopardizing the trauma practices that are delivering care and may have inadequate payment. I don't have a solution today, but I think what we'd like to do is spend a small bit of money to investigate what other possible options are for rebalancing that. And I'm uncomfortable with subsidies, but at the same time, I think the principles and the reason it's worked so well is up until 2014, payments were about 50-50 between the on-call stipends, the funding the capacity, if you will, and the other 50% actually funding trauma operations for physicians. So I'll leave my comment.
Okay. Thank you. Any further questions for Bridget and Karen? Okay. Thank you very much, ladies. That was wonderful. Thank you so much. The issue before the House is the approval to release the Maryland Physician Services Trauma Fund report. Do I have a motion?
With a friendly amendment,
Oh, well, okay.
what we said, but not limited to.
Not limited to.
Okay, that's
Okay.
what we got these.
Yes. All right, so that's the motion. All right, everybody's cool with that. Okay. All right, second the motion. Second, Commissioner Thomas. Okay, any further discussion here? All right, all those in favor say aye. Aye. Those opposed? Good.
Thank you very
Got the
much.
report, go for it. Thank you. Okay, thank you. All right, item 9 is dealing with the annual mandate report. We have to produce a mandate report every year. This is a new one. It deals with the coverage of fertility preservation procedures for iatrogenic infertility. I hope I pronounced that correctly. Maryland law requires that the Commission annually assess the impact of proposed mandated health insurance services that failed to pass in the last session and were submitted to the Commission by a legislator by July 1st each year. This past spring, the Commission received a formal request to assess a proposed mandate for insurance coverage of fertility preservation procedures for iatrogenic infertility. The report is due to the General Assembly by December 31st. The Commission's consulting actuary, Donna Novak, is the founder of NovaRest. Karen Bender, a subcontractor of NovaRest, is going to present the reports. So both of those consultants are joining us via webinar, right? Right. Okay, and Janet, you'll be at the presentation table, so all right, let's go. Okay, ladies. Can you hear us?
This is Donna. Good afternoon. Karen and I are really happy to present a summary of our report today. And if we go to our slide presentation, I guess that once the slides come up, Novarest specializes in helping state insurance regulators, and almost all of our clients, with very, very few exceptions, are state or federal insurance regulators. We've done over 40 mandated benefits evaluations for states, as well as many, many other services. Next slide. A couple of comments. Next slide. A couple of comments about this report. We cited all of the information that we found that we considered credible, which means sometimes there could be some conflicting information in the report, but we felt we wanted to present an unbiased view, and that often meant that we would present both sides of an issue. And I'm going to turn the presentation over to Karen, and she's going to go through information about the actual bill itself and the services covered and the current status of that coverage of those services in Maryland.
Hi, can you go to the next slide, Janet? Okay. Senate Bill 918, as stated before, would require carriers, essentially health insurance carriers, to provide specified fertility preservation procedures associated with the iatrogenic infertility. Do you want to go to the next slide, Janet? Okay. And I said, as I referenced before, this only applies to entities selling fully insured contracts. It obviously does not apply to self-funded, and insurance and HMOs are both considered under this bill. Next slide, please. We also wanted to include the ACA benchmark plan, and which is the current, the 2017 one, and going forward, that is the CareFirst Blue Choice HMO HSA HRA $1,500 plan. And for reference purposes, this does not include fertility preservation for iatrogenic infertility. You want to do next slide? And iatrogenic infertility is defined for the purposes of this study as a medical treatment that will likely have a side effect of infertility, and it's defined by these various agencies. And the law, or the proposed law, would establish procedures to preserve the fertility prior to the treatments that will cause the infertility, as long as those procedures are consistent and establish medical practices and professional guidelines. Go to the next slide, please. So the established procedures that we studied were the three listed under the first bullet: sperm cryopreservation, embryo cryopreservation, and mature egg cryopreservation. Boy, that was a tough one to say. Now, there could be other procedures that are available, but we really didn't consider them in our pricing at this point in time, because they are considered investigational at this time, or they may not work in all circumstances. So it was the three top procedures at the top of the slide 8 that really focused on. And I should interject right now that generally, but not always, the infertility occurs as a result of treatment of cancer, but it's not always that. Next slide, please. Now, infertility benefits are often available after a diagnosis of infertility, and that's why this particular situation doesn't quite fit in. It's sort of like the square peg in the round hole here. That normally, in order to get a diagnosis of infertility, there's a certain criteria, like going maybe 12 months or 24 months of unprotected sex and not being able to get pregnant. However, at the time that fertility preservation would be occurring, technically the person could be fertile, doesn't meet that circumstances, but due to the upcoming medical treatments, they probably will end up being infertile, and then there may not be any alternatives as a result of the treatments that they have to have. Fertility preservation is generally not available. We'll get into some of the states that passed. What I'm going to cover is just some comparisons with other markets. The EHB benefits that I referenced before, fertility preservation is not covered. Infertility benefits are provided after the diagnosis of infertility, and that's where we get into the sort of the catch-22 here. For the large group, most of the carriers that we surveyed indicated that they do not cover fertility preservation, and Maryland Medicaid also does not cover fertility preservation. Next slide, please. Slide 11. Okay. There's really only one carrier of the top 5 carriers. We did a survey of the top 5 carriers in Maryland. There's really only one that routinely covered fertility preservation, and that was in the group market because that particular carrier is not in the individual market. Most of the other carriers, Carrier 2, had language that specifically excluded certain parts of fertility preservation. And for large group clients, I mean, that's their standard verbiage, but for large group clients, there was more flexibility, although it was somewhat rare for them to cover it. Next slide, please. Carrier number 3 never covered it, and carrier number 4 did not cover it. Carrier number 5 indicated that they do not cover it for their individual small and large group markets, but they do cover certain services for the treatment of involuntary infertility for males and females. Again, that gets to be the timing issue. Donna, I think you're going to take over from here.
Yes, I am. So we're looking at what other states are doing. California has a proposed bill that would be very similar. Connecticut passed a bill, and so they do have this requirement as a mandate. Next slide, please. New York also has a pending bill that would have very similar coverage, and Rhode Island passed some legislation a little bit different. The policy would have to already include pregnancy-related benefits, which would apply to individual and small group, but not necessarily large groups. So they had a stipulation in their bill different from what Maryland has. Next slide, please. So the analysis that has been done in the other states that we could find, California thought that this would be about 0.041% of premium. We couldn't find any data to convert that into a PMPM, but in Connecticut, they did estimate on a PMPM basis of around 6 cents, both for individual and group plans, which we converted to a percentage of premium using information that was publicly available as about 0.01% of the individual policies and for the small group. Next slide, please. We did a survey in Maryland of the carriers for a lot of information, including their estimate on the impact on premiums. The one carrier that already covers it, obviously there would be no impact on premium, But for three of the carriers that did provide an estimate, there was quite a large range of estimates of what the impact would be, anywhere from 3 cents to $1.50. Next slide, please. We did our own estimate using a combination of national data and the survey data in Maryland. And we did it for each market, although we're not attorneys, and so we can't comment on what market would be covered by this bill, but we did the estimate for the individual, small group, and large group markets. In the individual, we did two scenarios. The largest impact, of course, is from women having a fertility problem. The cost for men is significantly lower, and I'll get into some of those assumptions in the next slide. But we did two scenarios. One of 25% of the women would opt to have the procedures, and another that 33% would opt to have the procedures. And there are footnotes in our report as to where those came from. But we were pretty comfortable with those just from a logic perspective. We talked to a lot of experts and advocates throughout the country, and there was no actual data, but the ones we talked to felt that these estimates, these assumptions, were not unreasonable. In the individual market, that translated to 14 or 18 cents PMPM. In small group, 18 cents to 24 cents PMPM. And large group, the same amount, 18 cents to 24 cents, which results in approximately 0.04 to 0.06% of premium in Maryland. The next slide, please, lists our assumptions. And the important ones really are the 25 and 33%. But this slide also includes the cost that we understand is pretty common, and we feel it would be representative of what the cost would be in Maryland. So for sperm cryopreservation, it's about $500. And for embryo or egg cryopreservation, it's between $12,500 and $13,000, so it's pretty close. I should mention here, because it's not on the slide, we did not include any cost for the actual storage after the cryopreservation. We didn't feel that it was covered by the bill. The storage costs are about $500 a year. Next slide, please. So the next couple of slides go through our typical questions around mandated benefits. The cost the first one is, would it increase or decrease the cost of the service? There is a possibility with any mandate of a service that hasn't previously been mandated that it could increase the cost because of the insurance coverage. But the increase in cost we did not feel would make a significant impact on the estimate on the PMPM impact on premiums. But there could be an increase in the cost. Usually that takes place over time. The next one is the increase in the appropriate use of the service. Right now, the service is not hardly covered at all, so it would increase the appropriate use of the service. One carrier was concerned that the definition of iotropic infertilization was too broad, and that it could increase the use in an unintended manner. And we have no comment on that. Also, is it a substitute for a more expensive service? And it's not a substitute for any other service. Next slide, please. The administrative expenses, the carriers did voice some concern about administrative expenses and difficulties in coding. I have experience implementing claim systems, so I understand that sometimes there is an initial impact on figuring out how to code claims or if doctors are coding them correctly, but usually that works itself out over time. They didn't quantify their concern about administrative expenses. Administrative expenses are typically, in total, about 25% or less of claims, and which is about 20% of the premium. But if there's a new mandate, all of that 25% doesn't come into play because the 25% includes overhead and accounting departments and a lot of expenses that would not necessarily increase because of a new mandate. And I guess we feel, I guess I can say we feel that any increase in administrative cost would not change our estimates of the impact on premium. Next slide, please. So the total cost of health care, we really feel that because of the total cost of health care nowadays, that this benefit would have a minimal impact. It would be an upward impact, but it would be minimal as far as a percentage of the total cost of health care. The employer's ability to purchase health benefits. Usually the concern here is small employers deciding to go self-insured because of the cost of mandates and being able to have some relief there if they became self-insured. The cost of this mandate we consider to be small enough not to have that impact, but I feel obligated to caution everyone that I do a lot of these mandated benefit reviews, and often the cost of each one of them is small, but the cumulative cost of all of the mandates starts becoming large enough that it can have a significant impact. So although the cost of this mandate we estimate to be relatively small, it would add to the total cost. Next slide, please. And now I guess it's open for questions. If anybody has any questions for Karen and I, and we will do our best to answer them.
Commissioners? Anybody have any questions? Mr. Director?
So I want to thank Donna and Karen. I'll also note that Donna is talking to us from Phoenix, Arizona, and Karen is speaking from Green Bay, Wisconsin. Sort of speaks to the nature of work today, that they worked together in the past and have done great jobs and have continued that in this effort. Carrier did call me this morning and wanted to say, how hard this would be to implement, as it's a service that would be available at a time when the actual condition triggering the service would not yet prevail. Did you have any thoughts about how, Donna or Karen, on how that would be implemented in a insurance contract? What sort of requirements a carrier would want to impose to?
Well,
I mean, it all seems like all of us might want to have preservation for a variety of purposes, and obviously that's not the intent of the bill.
Yes, you're absolutely right. Good point. We've talked about this, and I guess the bottom line is that we feel that carriers could use managed care methodologies such as pre-authorization and confirmation that a person has cancer and is going to have chemotherapy or any of the other procedures. Chemotherapy is the most common, that would result in infertility. So I don't think, I think using managed care techniques, abuse could be avoided. Karen, do you have anything to add to that?
Yeah, well, I think we could probably learn from the one plan that currently has it, and they indicated that prior to, it's sort of like a pre-authorization process, and that there has to be a diagnosis and planned and a treatment plan that verified by a doctor that says that the likelihood of infertility following this treatment plan is highly likely. So I think that, and I think those are the kind of managed care procedures that you're referencing, Donna. So I do think that it can't be maybe just carte blanche, although I'm not sure that anyone really want to go through all this for that. But and there could be some. I want to emphasize while the major one is cancer, there were some other medical conditions and treatments that were are given to those medical conditions. They're relatively rare that could also result. So it's not totally cancer, but it's predominantly cancer, predominantly either chemo and or radiation therapy. So I think it could be handled by, like we said, requiring prior authorization and having, as part of that prior authorization, having this treatment plan with a doctor stating, yeah, if you go through this, unfortunately, you probably are going to be sterile thereafter.
Just a question, or?
Here's a question. Fascinating report. You made reference to the fact that the storage is $500 a year. How many years?
That's interesting. This is the second time we've gotten that question. Before fertility procedures can take place, the person has to be cancer-free. So normally that takes a period of time, let's say just 1 or 2 years. Then technically for in vitro fertilization, the person has to show that they're sterile for 2 years. But so you can't just add those up though, because we focus a little bit on the women, but the same thing would be true for a man. If a woman went through this procedure, was cancer-free, then even though she has eggs that have been frozen, she needs a partner. So, or at least ideally, she has somebody that she wants to, have a baby with, and that may take some time. So saying that a 16-year-old has this happen, it could be 10 years or more before she was interested on freezing the eggs and having them fertilized.
It's only in my ignorance. Who's bearing the cost of that storage? The patient or some insurance provider?
It would be the patient. There are some organizations that will provide some financial support for the preservation, the fertility preservation, but I don't know that they actually cover the storage.
Okay, so I'm 2 years in, 5 years, 2 years in, I lose my job. You gave me a 10-year window. Do they unfreeze my eggs and toss them out? What do they do?
That's a legal question. It's to do with the contract that she has or he has with the organization. I don't know the answer to that.
Thank you. Dr. Peters.
Also, because we're dealing with mostly cancer, what happens if that patient doesn't survive? What happens to the eggs or the embryo?
There are a lot of complicated, interesting legal questions around this, and that's one of them. Can the grandparents use it?
Commissioner Wang.
Yeah. But really, that was outside the scope of our analysis.
Sorry, Donna. Normally, that's something that the patient would sign with the fertility clinic or the doctor, and in those consent forms they sign, they talk about, how long, what's going to happen if they can't keep their payments up, what happens in the event that they divorce, they die, something happens, what the disposition of that tissue is going to be. So those are normally things that are done in a contract reform, independent of this insurance mandate.
Okay. Any further questions?
So,
Yes.
Yeah, I just note that, this is a bill that was introduced last session, did not pass, of course, that's why it ended up at us. It was sent to us on the assumption from the leadership that they thought it would appear. So we can't necessarily say as a result of this study that on reading it, someone wouldn't say that storage costs need to be factored in. Don't say that would be true or false in either way, but that's certainly a consideration. It's also true that insurance is renewed on an annual basis and it's subject to changes in employment. So you're not really ever going to get away from some of these really tricky legal questions.
So I would just suggest that while they are clearly legal, they are also ethical. And so if we continue along this path to have some bioethics framework to really think about this carefully.
Well, are you suggesting that we don't release the report because of bioethical concerns?
No, I would not hold up the report, and I haven't read it thoroughly enough to know if they've excluded any reference to bioethics. Legal has come up several times.
Well, actually, they have referenced this problem. Let me put it this way. I think if we send this report, the communication to the legislature has got to be very clear here. I will explain my concerns about this. Number one is, as Ben knows, I think, frankly, we have mandated the health insurance system really quite enough. And what has happened over the past several years is and I think the consultants are very clear about this. In fact, on page 29 of their excellent report, they say, it is not the cost of any single mandate that drives employers to self-insure, but rather an accumulation of multiple mandates. The ACA already has several components that appear to incent employers away from fully insured plans, including EHBs, the health insurance tax, and in the case of employers with 50 or fewer employees, benchmark plans and medal level plans. Now, here's the point. We've had a report, I think, 2 sessions ago that the average premium in the individual market's going up, 30% plus. All around the country, we've had, big increases. Obviously, under the law, under the federal law, any mandate that we impose is imposed not as a tax. We have federal mandates, we have state mandates, but the state mandates are going to be another tax on Maryland citizens. We've got to keep that in mind. I think it's absolutely true that you can take any very specific, medical treatment or procedure and say this is a very good thing for the following reasons for particular classes. But when you start to accumulate them over and over again, what you're doing is you are making health insurance less and less affordable for more and more people. And we have to keep that in mind. The second thing I would mention, you brought it up, and I think it's a very good point. This is not just simply another mandate. This is a more serious issue in many respects. On page 9, the consultants write, talking about the question of, the preservation of embryos. Quote, there are ethical, legal, and religious implications regarding the disposal of embryos in the event the patient dies before they can be implanted or if the partners separate. This is not something we should take lightly. In communication with the legislature, we should make it clear without lecturing them. I'm not talking about lecturing them. We should make it clear we consider this a serious matter. And frankly, that's a very fine quote to include in the cover letter, as well as the wonderful quote on page 29, that, there are a lot of things we would like to see in health insurance. But the fact of the matter is this is not anymore a consumer-driven system. This is a situation where we have people being told what they must have and under what circumstances they must have it. And when we start to get into an area like this, and Dr. Peters, you actually started to bring this up, we start to get into an area like this stuff gets really tricky. And there's a lot of very thorny issues here. And I just think we ought to, I'm not talking about lecturing the legislature. All I'm saying is that communicating to them very clearly that we consider this a very serious matter. It's not simply a matter of dollars and cents. That's my view of the matter anyway. Commissioner O'Grady.
I'd like to support your position on keeping the number of mandated benefits to a minimum, because I think we have seen that over time. At the same time, I think this report is great, candidly, because now you have a neutral third party who has put these per member per month figure estimates out and talked about percentage of premium. So our friends in the insurance industry have a certain neutral third party putting this forward, which their actuaries can verify. And as you say, there's a plan in the state that already does it. So there's kind of two ways you could go here. If you stick with a mandated kind of route, and you can, correct me if I'm wrong, Donna, but you can, you know, if you said you wanted to put in a 5-year, we'll pay for 5 years of preservation, or, you know, 10 years if you're under a certain age, and 3 years if you're over a certain age, you can, I assume you can estimate the per member per month and the percentage of premium of that, you know, expanded benefit to cover some of storage and upkeep and that sort of stuff. At the same time, good, thanks. But at the same time, kind of back to the industry, if you see that there's a demand for this, and you see that it's fairly, you know, the estimates are that it is not a budget buster. The one way to avoid the possibility of mandate is just add it to the benefits voluntarily. If you find it's very expensive and you need to remove it later, that's a different discussion. But there's also a notion here of, I think that's the value of this neutral third party estimate of what this costs. This is something that I went through at the federal level over expand what they used to call, you know, mental health equity issues. And part of what calmed that whole debate down was a neutral actuarial analysis from FEHB that said, okay, by executive order, we covered this for the last 2 or 3 years. Here's our claims. Here's what it costs. Here are the groups that kind of use it a lot, and here's who don't. And it was just sort of, you know, it wasn't as expensive as industry was concerned. It wasn't zero like the psychologists were trying to say. It was somewhere in between. And so I think this report, I certainly support it, and I think it's a great addition to the debate. Whether you go mandated or you go voluntary, now you've got the tools you need to know what you're doing.
Yes, Marcus.
Chairman Moffitt, first of all, I completely agree with you. Number one, we have to be very, very thorough and cautious when we address the ethical implications of this issue. Number two, I think we also have to be very cautious about imposing another burden on taxpayers. And I think, you know, looking at this, as Michael said, it's a very excellent report. You look at pages 13 and 14 and talk about numbers. And the number of expected cases in Maryland, if I've done my addition correctly, you're talking about just north of 2,000 expected cases in Maryland. 1,327 female, 731 male. 2,058 cases out of 5.78 million in the state. So you're looking at 0.036% of the population that will be affected by this. And we have to wonder if that's going to be worth imposing another burden on the taxpayer through a mandate.
That's a very excellent point. Donna, I want to ask you a very specific question again. I'm going to turn it over to Commissioner Sargent. Reading your report, did I read it correctly? Did I read it correctly by saying that the only other experience with states is the fact that other states like California have introduced legislation, but is there any state where this is actually operable as a mandate?
No. Well, that are mandated, but there's no experience available at this time.
There's none.
Yeah, I think there's a couple of states that, Donna, that have already passed and it's effective, but you're right, there's no time to, there hasn't been any time since its passage to gather.
So if Maryland would do this, Maryland would actually, all right, okay, I just wanted to make sure I was clear about that. Commissioner Sargent.
Thanks. And I agree with everything you said. I had a question just on the methodology. If you look at these sorts of mandates in this day and age, what you're really talking about is the small employer market and the mid-sized employer market. The large employers are largely gone. You sell almost no insurance policy. They're self-insured. The individuals, the state would need to provide a subsidy to provide a new mandate, and the state often does not seem willing to actually pay for the mandate itself. When it subsidizes, like on the exchange, the federal law says you have to subsidize if you add to the essential health benefits. So we're talking about small employers. The methodology here looks good for the small employer market under 50 because they're rated equally across the entire pool of small employers, so you could average the cost of this mandate over everyone. But when you get above 50, different carriers experience rates the group. They're allowed to look at the group medical history and rate different groups differently depending on how sick or healthy they are. And the larger the group, the more likely that is. Different carriers sometimes use a combination of experience rating and the entire pool for groups that are, say, 60 people. Some, they just do it differently. Have you looked at, for these sorts of mandates, where groups are being experience rated? And over 100, I think they're pretty much all experience rated. That cost for particular procedures would fall more heavily on some groups than others. And where it's a procedure that falls within certain age ranges or something, it may fall more heavily on certain bands of members than others. So if it's for fertility, you might think that that's going to increase the cost of people in the age range where there'll be, when you're doing the rates for the individual contributions that are more likely to be in the fertile period of their lives. I don't know how you do that, but if you looked at your methodology, you're trying to figure out where this thing where some groups may pay more and some groups may not pay anymore because of their claims experience, how you would do that analysis. Because, well, I like what you've done here to try and find a PMPM for the whole market. I'm not sure it really talks about how the cost would be apportioned. And maybe that can't be done. I just want to know if you looked at it.
No, with the large group market, we have information on the market as a whole, but not on any particular group. But you're absolutely right that a group that had more individuals between the ages of, say, 16 and 39, 49, they would have more of an impact than if you had a group that was skewed more toward older individuals, 40 and over.
Any further questions? All right, I think, I just want to make sure we're all on the same page here, okay? If we're not, then we won't do it. But here's my point. I think in the letter of transmission, I don't know who signs that, but I'll sign it if nobody else wants to. I think we ought to say that, number one, the point that they make about that in and of itself, this is not an expensive, point. But nevertheless, that we ought to say to the legislature, remember, the multiplication of the mandates does have an impact on cost over time. Frankly, we should quote that. We should also quote the fact that there are, in fact, incidental to this, there are, their language is fine. There are profound ethical, moral, and religious questions with some of this. And finally, I think we ought to just say to them that based on our experience here and the wonderful work that's been done by our consultants, nevertheless, there is no real experience in other states with this. Does everybody pretty much agree to this approach? It doesn't change the substance of anything, but I think we've got to start telling the legislature they've got to really start thinking deeply about these matters rather than just, doing good, before breakfast, with the taxpayers' money. Yes, Mr. Director.
So, yeah, that, I think we can draft the letter. It would be similar in the approach to what we did last year, which was, the request to us is provide the estimate. Then we provide some commentary in the cover letter. Last year we said, somewhat the same thing, raised the concern about mandates. One of the mandate bills passed the digital imaging for digital mammography. The other one did not pass. So you could argue that they listened to us on one and went a different direction on another. And we'll follow your same instructions this year.
All right. Okay. Are there any further questions at all? I have then the motion here is to, Well, we want to make sure, first of all, we got to approve the release of the report, right? So, well, okay, you're getting ahead of yourself. Do I have a motion to approve the report? So, okay. All those in favor say aye. Aye. Good. Yeah, you second. Want to move along quickly. All right. Thank you. Ben, you're anxious. There we go. Ben, upcoming events.
CON study group. The 5 commissioners that agreed to serve, Commissioner Phillips, Sergeant, having been co-chaired, other commissioners including Commissioner Brady, Commissioner Metz, and Commissioner Casey. We will also, sorry there, getting long in the day. And we will be sending out a solicitation letter to interested stakeholders seeking nominations for other members of this work group very shortly. Accompanying that letter will be some structured questions that we'll ask stakeholders to comment on that largely mirror some of the questions that were raised in the chairman's letter to us, as well as questions commissioners have raised over the ensuing 3 to 4 months. We think the responses to those questions will provide a framework for the discussions of the work group going forward. We would expect to bring the nominations to the work for the work group back to you in December. In December as well, I know Commissioner Sargent was interested in the breach assessment study that will be presented at that time. We have also I've asked Teresa's group to prepare a work plan for making information on quality in the outpatient setting, specifically ambulatory surgery available. They will lay out the approach over the next year. We expect to have 2 CON adjustments, or we expect to have RCA coming back before us to make adjustments to the CONs that were issued last year about this time. And we possibly would expect one other issue, notwithstanding what David already said, the proposed regulations on privacy and security could potentially be brought before you, but we want to work with the AG and other parties to make certain we're all in alignment before we're going forward. That said, I think, again, to emphasize that there is a governor's hold on regulation. So an additional process that occurs is that when you approve a reg for review, I submit a exemption request to the legislative officer in the governor's office that we report to. They then make a determination on whether they're going to allow those regulations to go forward. The regs today, we hope, would be approved to go forward, but it's an independent decision on the part of the governor's office as we move through this process. So I wish everyone a very happy Thanksgiving. If it hadn't been so long, I had some turkey questions, but we'll have to forego those for now. Thank you.
Thank you very much. Right now, I'd like to entertain a motion to adjourn. So moved. Have a second? Thomas, right there. All those in favor say aye. Aye. Okay, let's get out of here.